Good morning, everyone. Let's have the video presentation of the introduction of our ACLS. Full volume po tayo.
Leticia,
Hey Jack, what's up?
happy Monday. When you finish with this, I need you to clear off the end cap down there. I got a whole bunch of promotional items coming in. We got to put them somewhere.
Okay, sounds good.
Oh,
You all right, Jack?
yeah. Yeah, I'm fine. I think it's that stuff that everybody's got going around.
Okay.
Acute coronary syndromes, or ACS, may suddenly strike men and women, often after years of asymptomatic coronary atherosclerosis and plaque formation. As plaque forms within the coronary arteries, several clinical syndromes may also develop, with varying degrees of coronary artery occlusion. Two of these syndromes are non-ST segment elevation acute coronary syndromes, or NSTEACS, and ST segment elevation myocardial infarction, or STEMI. STEMI is generally considered to be more serious and usually develops after a ruptured plaque or an erosion results in an acute blood clot that significantly or completely occludes a coronary artery. Either of these syndromes can, unfortunately, manifest as sudden cardiac arrest and death. It's estimated that half of the deaths from these syndromes occur outside the hospital, making early recognition and rapid response essential. The best outcomes from ACS occur in communities where programs with strong public education, PAD programs, and STEMI systems of care exist. Watch how emergency medical services and hospital personnel use the STEMI chain of survival to provide a system of care that recognizes and rapidly treats the underlying causes of ACS.
What's going on?
I think Jack's having a heart attack. I'm gonna call 911. You get the AED and first aid kit.
Okay.
911, what is your emergency?
I think my manager's having a heart attack.
I see you're located at 459 Commerce Avenue, is that correct?
Yes.
Where is the patient?
He's right here. He was wobbly on his feet, so we sat him down in the aisle. He's having chest pains and his left arm hurts.
Is he awake? Can you talk to him?
Yes, he's awake and able to talk.
I'm going to dispatch paramedics to your location. Stay on the line with me, okay? Don't hang up. I'll have a few more questions to ask you.
Okay.
The first step in the ACS algorithm involves the patient, bystanders, and medical personnel recognizing the warning signs of cardiac ischemia.
We all had basic first aid training and CPR training about 6 months ago, and when Jack said his chest was hurting and his left arm was hurting, that's when the alarm bells went off for me.
Our system uses priority dispatching protocols, which help identify the problem and determine what type of response to send. What the caller described fit the protocol for ACS, which required a high priority EMS response.
While waiting for EMS to arrive, dispatchers may advise patients to chew 160 to 325 milligrams of non-enteric coated aspirin. This recommendation should be in line with approved medical protocols, and only if the patient has no history of true aspirin allergy or gastrointestinal bleeding.
Okay, paramedics are on their way. Stay on the line with me until they arrive. Do you have a first aid kit with you?
Yes, and I have our AED too.
Great. Is the patient still conscious?
Yes, he is.
Okay, then we won't need to use the AED right now. Ask if he has an aspirin allergy or any recent bleeding from his stomach.
Jack, do you have an allergy to aspirin?
No.
Have you had any bleeding in your stomach recently?
No, I don't think so. No.
No to both questions.
Look in the first aid kit. If it has aspirin, have him chew 2 to 4 baby aspirins or 1 adult aspirin while you wait for the paramedics to arrive.
That brings us to the next step in the ACS algorithm: assessment, care, and hospital preparation.
What happened?
He's been having chest pains for about 10 minutes. The 911 operator said to give him an adult aspirin to chew.
Sir, how you feeling?
Not so good. It's my chest. I feel like somebody's squeezing it.
Okay. Well, we're gonna help you out, reduce that pain. I'm gonna get a 12 lead. Go ahead and get his blood pressure and put him on a pulse ox.
When we arrive on scene, the clock is ticking. I know I've got to assess, but if he doesn't need immediate resuscitation, my highest priority is to obtain a 12-lead ECG, manage the symptoms, initiate transport as soon as possible. Every minute matters. The longer it takes to get to the hospital, the poorer the outcome for the patient. In fact, half the people who die from ACS are dead before they even reach the hospital. So I follow the ACS algorithm closely just to make sure that doesn't happen.
Administer supplementary oxygen if the patient's oxygen saturation value is less than 90%. Give aspirin if the patient hasn't taken any yet and there are no contraindications. It's critical that out-of-hospital healthcare providers obtain a 12-lead electrocardiogram.
Looks like a STEMI.
This early ECG helps classify patients suspected of having an ACS into two groups based on ST segment deviation before they reach the hospital. It's preferred that patients with ST segment elevation be driven, if feasible, to a hospital that performs primary PCI. This initial ECG speeds the patient's diagnosis and shortens the time to reperfusion.
Recognizing ST segment elevation on a 12-lead ECG takes training and practice because different thresholds exist for patients depending on their age and gender.
If a STEMI is suspected, EMS should notify the hospital or transmit the ECG for interpretation.
The patient had ongoing symptoms of ischemia, so we administered nitroglycerin sprays every 3 to 5 minutes for a total of 2 doses. 3 is the max. We monitored the patient's blood pressure in between each dose.
Before giving nitrates in any form, make sure there are no contraindications, such as severe bradycardia, tachycardia, or hypotension. Also, confirm that the patient hasn't taken any phosphodiesterase inhibitors for erectile dysfunction in the past 24 to 48 hours. Patients with inferior wall STEMI on their 12-lead ECG can often have right ventricular involvement. This can be confirmed by a right-sided 12-lead. If RV infarction is present or suspected, nitrates in all forms are contraindicated. Clinically, it may be suspected in patients with hypotension, clear lungs, and elevated JVD. If the patient receives nitroglycerin but does not experience pain relief, healthcare providers can consider giving analgesics such as morphine while monitoring the patient's blood pressure and respiratory rate. Use morphine with caution for patients with unstable angina.
County Medical, this is Rescue 1. We've got a STEMI alert. 46-year-old male, chest discomfort started half an hour ago. Current vital signs are BP 104/78 with a heart rate of 96. Pulse ox 95%. He's chewed 325 milligrams of aspirin and received 2 rounds of nitroglycerin sprays, but still says he has chest discomfort. 12 lead shows ST segment elevation of 3 to 4 millimeters in leads V1 through V4. ETA to your facility is 10 minutes.
Rescue 1, we received your 12 lead and your initial report. We'll activate our heart alert system, contact the cardiologist and the cardiac cath team. We'll see you guys in a few minutes.
Let's get ready.
Getting this advance notice really helps us speed treatment of these patients, increasing their chance of survival. We can have the cath lab prepped and ready by the time the patient hits the doors of the ED.
The American Heart Association recommends that EMS personnel transport patients who have a STEMI to the closest appropriate facility that provides reperfusion without delay.
Hi, sir. I'm Dr. Taylor. We're going to take good care of you today.
After we last talked, his pain is down to 2 out of 10. Otherwise, he's stable.
Let's get him to bed.
Right. Studies show that ED evaluations are responsible for as much as 33% of the total time from symptom onset to treatment. We try to reduce delays by having everything ready when the medics arrive. After seeing the 12 lead that the medics had sent, I immediately activated a PCI team and alerted the cardiologist.
When the patient arrives at the ED, we move to the next step in the ACS algorithm. Reperfusion goals for STEMI patients include PCI within 120 minutes after the first medical contact, or fibrinolytics within 30 minutes from ED arrival. The appropriate therapy is defined by patient and center criteria.
Within the first 10 minutes after arrival, the ED staff should provide an immediate assessment of the patient. That includes taking vital signs, getting a brief, targeted medical history, completing a fibrinolytic checklist, and obtaining blood studies. If the early ECG shows no signs of ST segment elevation, then a repeat ECG in the ED is warranted. Staff should also get a chest x-ray within the first 30 minutes after arrival. Draw the STEMI panel. I've activated the STEMI pager and get him to the cath lab as soon as they're ready.
Adjunctive treatments include unfractionated or low molecular weight heparin, bivalirudin, P2Y12 inhibitors, IV nitroglycerin, beta blockers, and glycoprotein 2B3A inhibitors.
Hi, I'm Dr. Taylor.
Hi, how is he? Did he have a heart attack?
I'm afraid so, but his vitals are improving, and we're moving him to the cath lab. This is going to allow us to see inside his heart and his arteries and treat it as well. Dr. Abrams is an excellent cardiologist, and he'll be helping you through the next steps. You'll be in good hands with him, okay?
Thank you.
This patient presented with ST segment elevation of 3 to 4 millimeters in leads V1 through V4. Now, this suggests that his LAD artery is occluded. Immediately opening up the artery with PCI and restoring normal blood flow is my primary goal.
The final link in the STEMI chain of survival is treatment. The preferred reperfusion strategy for STEMI patients is PCI, when patients meet the 120-minute window from first medical contact or 90-minute window from ED arrival to balloon inflation in the catheterization lab.
Hi, Mr. Brennan, I'm Dr. Abrams, your cardiologist. How are you feeling?
Not so good.
Well, hopefully you'll be feeling a lot better soon. I just want to talk to you a little bit about what's going on. I've reviewed your ECG, and it appears you have a blockage in one of the arteries to your heart. Now, to open the artery, we need to perform a procedure called PCI that'll help reestablish blood flow to your heart. Basically, we insert a catheter into the artery with the blockage and inflate a balloon to widen the blocked area. We then place a stent to keep the artery open. And the sooner we can do this procedure, the less damage may be done to your heart, okay?
Okay. I understand. I'm ready.
All right. Well, let's see what we can do to help you get better, okay? All right.
PCI opens the blocked artery with a tiny balloon. Then a stent, or metal scaffold, is inserted to maintain blood flow to the heart. When choosing between this reperfusion strategy and fibrinolytic therapy, hospital personnel must consider a number of factors. Studies show that treatment delays increase mortality in both groups, regardless of the reperfusion strategy chosen, but were more pronounced among those patients receiving fibrinolytic drugs. In these cases, the more time that goes by, the more heart muscle is lost. The better EMS systems and medical centers work together, and the faster they can deliver treatment, the more heart muscle and patients can be saved.
We had a great outcome with that patient, but we wouldn't have if every link in the chain hadn't been working cohesively.
All the pieces fit together perfectly, and it all began with a call from his coworker. The dispatcher assisted in the administration of aspirin prior to our arrival. We were able to get to him in time, identify a STEMI, and move him quickly to a hospital where they were ready to do PCI. He's back at work today because of it.
Hi, good morning. And let's begin our day na po. Let's have the online kamustahan muna. And before I begin, I'd like to ask, no, how is everyone po? Kamusta po ang lahat? And I hope po na wala pong sasagot ng okay lang. Kasi it's so unfair sa mga taong hindi na po nagigising, di ba? So we need to be grateful na every morning po. Kasi mornings are blessings, okay? And so let's begin. So we have the first topic known as ACLS, or Advanced Cardiovascular Life Support. And but before we begin, sa ating ACLS po, we need to have a strong foundation sa ating ECG and pharmacology. So sa morning po, na puro ECG and pharmacology po tayo. And then before approaching lunch na po, and we'll be having yung mga protocols po na ng ating ACLS. So let's begin. So again, I'm Mark Jade Adlawan. I'm from Davao City also. Saya din ako. So shout out sa mga bisya din na nasa groups. Okay. My objectives na for this morning, guys, is of course na for us na to be updated. We will be following the 2021 and the 2020 guidelines na for the ACLS. Meaning to say, updated po ito in combination na with COVID protocols. Meron din tayong mga COVID protocols na madidiscuss po natin later. Okay, let's have the anatomy review. Now, when we talk of ECG kasi, the system that's included po, it's basically the cardiovascular system po natin. Now, we have the coronary arteries po na. So, as you can see sa ating picture, guys, and so we have the myocardium there, diba? The pericardium, etc. So, the biggest muscle po natin, which is the myocardium, which is responsible nasa pag-contract ng heart po natin. Now, And we will talk of, okay, more of the polarization. Kasi pag sinabi po natin polarization, dalawa ang nangyayari eh. Pwede kasing depolarization, and then we have the repolarization. Now, when we talk of polarization, this is the readiness, the ready state, okay, ng tinatawag na body po natin, ng heart po natin. Pwedeng mangyayari si depolarization, at saka pwedeng mangyayari si repolarization. So let's start with the word depolarization. Guys, when we say depo, sabay-sabay nga tayo. Everybody say depo. You can unmute naman po, no? Try lang natin para at least we can actually, determine kung okay ba.
Depolarization.
Thank you po. Si Peter Manuel Oliva po ba yung doctor po natin? Tama po ba ako?
Yes, sir.
Hi, hello po, Doc. Good morning po. Good morning,
Good morning,
doctors, nurses, midwives, and medtechs po. Ayan, I hope no, na maganda po yung gising po natin, nakapag-breakfast na. Ang importante nakapag-coffee para gising na gising mode po tayo. Ayan, hello po, Doc. Sino pa yung mga doctors po natin in the house? Ayan, parang marami-rami din. Kahapon, marami-rami din sila kahapon, yung mga doctors po natin. Ayan, sige po. So we have depolarization. When we say depolarization, this is the stimulation. This is the contraction ng heart po natin. Na acceleration to be exact. Now, pag sabi naman natin repolarization, from the word itself, that means relaxation or the recovery state po. I just turned off na my camera or my video kasi parang bumagal ang konti na ang ating internet connection. Okay, so we have repolarization or the recovery or the relaxation. Ayan, state po natin. Okay, for a while. And so aside from that, ayan, we will be talking more of the conduction system ng heart po natin. Now, when we talk of the conduction system, my mnemonic goes like this. So I have a mnemonic known as your sublerp na mnemonic. Ayan, bakit daw sublerp, sir? Letter F, A, B, L, R, and then we have your letter P. Ayan, when we talk of sublerp, this is the conduction system ng heart. Letter S stands for the SA node. Next, we have the A. Next, we have the bundle of S. Next, we have the left and right bundle branches. And then to be followed by your Purkinje, okay, fiber po natin. Each node kasi po, na meron sa mga tinatawag na firing rate po natin. Are you aware, guys? Now, this is just a recall po ng ating conduction system. When we say this is the primary pacemaker. The primary pacemaker po. Next, pag sinabi nating AV node, this is the secondary, ayan, pacemaker ng heart po natin. And next, we have the bundle of his left and right bundle branches, and then we have the Purkinje fiber. Now, when we talk of SA node, what's the firing rate here? Pag sinabi kong F means the firing rate. Next, we have the firing rate also. Next, meron din tayong firing rate dito. Meaning to say, dito po natin masasabi na okay, if nagfa-function po si SA node, we can achieve that specific na firing rate or heart rate po natin. Since your SA node, guys, SA node is the primary pacemaker, so it is actually expected that the firing rate here is what? 60 to 100. That's the firing rate. And pag sinabi po natin 60 to 100 for SA node, kaya pala masabi natin na okay, normal ang heart rate ng isang patient. Now, for the F, okay, firing rate naman po ng AV node po natin, it's 40 to 60. So meaning to say, if 60 to 100 is the normal heart rate na, let's say, boundary po natin, or level po, meaning to say, pag bumaba po tayo ng 60, guys, papasok na po tayo sa tinatawag na bradycardia. Okay? Sabay-sabay nga tayo. Everybody say bradycardia.
Bradycardia. Bradycardia.
Yeah, thank you so much. Ayan, when we talk of bradycardia, iba po ang management na for adult patients and then iba din po na for our pediatric patients. Now, we have our Purkinje fiber with its firing rate 20 to 40 beats per minute. Meaning to say, since your SA node is the primary na pacemaker po natin, dapat siya talaga ang nagfa-function. Pero kasi if you have a problem with the SA node po, then na meron pa naman tayong secondary pacemaker, which is for the AV node. However, kasi 40 to 60 na lang po ang kanyang firing rate. Meaning to say, dito na po magsisimula ang mga tinatawag na bradycardia. And pag sinabi po nating AV node, familiar ba kayo sa mga, di ba? First degree AV block, second degree AV block, and then we have the complete heart block known as the third degree AV block. Okay. So dapat pala puro SA node lang po tayo. Pero pag nagka-problema si SA node, sige lang, may sasalo which is the AV node. However, pangit po ang heart rate po natin dyan. The firing rate will be 40 to 60 lamang po. I-compare mo naman sa 60 to 100. Guys, if that's less than 60, ano nga yung term natin? It's bradycardia. Now, I have a question. Ano naman yung term natin pag greater than 100? It's siyempre, walang tachycardia, ha? No? Malamang it's tachycardia. Sige nga, everybody say tachycardia.
Tachycardia.
You're the tachycardia po natin. So, I'm just checking lang, no, yung mga GCS status po natin. Ayan, no? So, kaya, di ba, always kung pinapaano na, everybody say ganito. Kasi gusto ko lang din na marinig at malaman kung may students pa ba ako or may mga trainees po. Maraming salamat sa mga pabalik-balik na lang ng mga trainees po namin. Like yung iba, no, third round na, fourth round na, yung iba nag-abroad na pero pinili pa rin kami, no? Sana all pinipili. Kasi nung nandiyan ako sa Albay, hindi po ako pinili. Charot lang. Umalis po akong syempre, no, decided, etc. So we have the conduction system ng heart po natin. So we have the sublurp, guys. So we have the SA node, no, the atrioventricular node, the bundle of His, the left and right bundle branches, then we have the Purkinje fiber. Again, ulitin ko lang, sino nga yung primary pacemaker po natin? Pag primary, we have the SA node to be followed by the secondary pacemaker, which is the AV node po natin. Now, diretso tayo ha. Okay, so we have the ECG. Now, the problem, okay, that we are facing right now is that, for nurses, ayan, medyo nakafocus kasi tayo sa ECG, pero hindi na po tayo nakafocus sa patient po natin. Sometimes, yes, na 75% tama talaga yung pinapakita ng ECG. However, kailangan din kasi tignan ang patients po natin na we need to re-evaluate din the client. Kasi may mga nangyayari po, akala natin nag-assistole ang client kasi nag-flatline si client. Pero si client mo naman is smiling, di ba? May ginagawa. Tapos alangan naman pupunta ka doon, dediretso kang mag-compress. Syempre hindi. You need to evaluate, sir. Bakit kaya nag-assistole to? Pero okay naman si client. Meaning to say, baka may mga na-detach na mga leads po. Okay? Baka may mga detachment of leads lang. Kaya nga, di ba, may protocol po tayo for the assistole. Number one, before mo sabihin na assistole, we always check for the pulse. To be followed by, we need to check for the Ecg Leads. Okay? And lastly po, we need to maximize the ECG 5 to 10 times in order for us to really confirm that it's your assistole or asystole or the flat line. Dapat may protocols talaga tayo. Now, with your ECG po, so ECG monitoring may be used for the following purposes. Number one, this is to to monitor the patient's heart rate. Yes. Kasi meron naman nakalagay kasi this is attached sa cardiac monitor po natin. We can evaluate po the injury, the extent of injury, and of course, the heart function. Lalo na pag, di ba, may acute coronary syndrome tayo. Kasi kanina po, with acute coronary syndrome known as the ACS kasi, na the number one problem there is the myocardial ischemia. Pag sinabi natin ischemia, there's this lack of oxygen supply. From ischemia, there will be injury. No? Then there will be necrosis. And from injury to necrosis po, there will be what we call the myocardial infarction, which is actually irreversible in nature. Now, to evaluate the pacemaker function, kasi magko-combine po yan sila later. Of course, to evaluate the response to medications, lalo na pag nagbibigay po tayo ng mga anti-arrhythmic drugs. Ano ba yung mga examples ng anti-arrhythmic drugs natin na very common? Anyone from the group? Amiodarone, which is a very common anti-arrhythmic or anti-dysrhythmic drugs po natin. The lidocaine also, na pinasok po ng American Heart Association 2020 guidelines. Next, this is to obtain a baseline recording before, during, and after a medical procedure, of course. Lalo na, if you are dealing with yung mga cardiac procedures po natin, may mga surgeons po ba tayo? Si Dr. Peter Manuel, ano po yung natin, Doc, specialty? So, ang area po si Doc?
Pedya.
Nice. Saang ano, Doc? Saang hospital?
Sa Irigas, Santa Maria Josep Foundation Hospital. I'm a pediatrician.
Hello po, Doc. Ay, nice, Doc. Yung ex ko din, Doc, pediatrician ng BRT.
Okay. From Legazpi.
Yes po, Doc. Yung malaking mama doon. Si hematologist na epidemiologist. Walang ibang malaking mama sa isang malaking doktor sa BRT, like literally na malaking mama talaga. And for sure nag-meet na kayo nun, Doc. So we have to evaluate for signs of myocardial ischemia, injury, and infarction. Kasi guys, pag sinabi po natin ischemia, it is actually expected na may T-wave po tayo, T-wave inversion. 'Di ba? Kaya nga ang term natin doon is ischemia. Kasi may T-wave inversion tayo. Pag may injury naman po, injuries ang term ko doon kasi may ST segment. Ayan, depression po tayo doon. Or ST segment elevation. Sorry, it's your ST segment elevation. And then lastly, pag may infarction naman po tayo, of course, that's your the pathologic Q wave. Okay, may mga Q waves po tayo which is pathologic in nature. Mamaya, i-differentiate po natin sa angina pectoris and then we have the myocardial infarction in which kasi, 'di ba, based sa hospital experiences po natin na pag 3 doses ng tinatawag na nitrates po natin or the nitroglycerin, 'di ba? Pag hindi pa rin po after 15 minutes, then we need to suspect na okay, this is an MI and not a simple angina pectoris. It can be relieved by nitrates. However, pag cannot be relieved by rest, cannot be relieved by nitrates, MI na po yun. Sir, paano ba dinidefine or dinidifferentiate nila ang pain? Sa angina pectoris po, parang stabbing pain daw siya. Parang kang sinasaksak sa dibdib. Pero pag sinabi na po nating MI, guys, na it's a squeezing one. And sometimes the patient will complain, sir, parang may nakaupo sa chest ko na parang elepante na sobrang bigat, na sobrang sakit na talaga. So depende po yan sa patients po natin, ha. So again, if that is unrelieved by rest and nitrates, we need to suspect na your patient might be suffering from myocardial infarction. Okay? Pero pag na-relieve pa sa nitrates ng nitroglycerin and rest, that's a simple angina pectoris. Pero that simple angina pectoris, na pag hindi po properly managed. So careful po tayo, guys. Okay, so we have the electrodes. Kasi ang electrodes kasi natin, yung mga color-coded po natin ng mga electrodes natin, magdedepende din talaga yan kung ano ang ginagamit po natin na defibrillator. Okay, so this is the best time for me to discuss defibrillation. Guys, we have two types. And the two types, okay, of defibrillators po natin. Number one, we have the manual defibrillator. So we have the manual. Ayan. Aside from manual, okay, we have the AED or the automated external defibrillator. Now, pag sinabi po nating manual, it should be a biphasic one. Pag sinabi po nating biphasic, dalawa pong, okay, let's say paddles ang magbibigay ng energy. Dati kasi phasic. This is for the mono and this is for the bi. Take a look sa ating mono. Ano ang itsura? Let's say, pag nag-defibrillate ka, this is your heart. Kunwari, heart mo yan. Pag sinabi nating mono, di ba naalala mo dati at 360 joules because this is the maximum. So from 360, boom, 360. Isang paddle ang magbibigay going to the right, okay, sternum of the patient. Right upper sternum. That's 360. So station yan. Why? Upon having yung mga, 'di ba, autopsy, habang in-autopsy kasi ang patient natin, they discovered po na kaya pala namatay ang patient because of defibrillation and not brought about by cardiac problem. Ayan, and alam niyo ba kung anong nangyari, guys? May mga tinatawag na burnt myocardial cells. Okay, so nasunog ang myocardial cells ng patient. Kaya nga, na they get rid of the monophasic. So wala ka nang maririnig dapat ngayon sa ER na sinabi ng doktor at 360. Wala na po yan. Why? Kasi ang ginagamit na po will be the biphasic defibrillator. So, erase na tayo. Let's focus more of the biphasic. Everybody say biphasic.
Biphasic.
Ayan, thank you so much. Ayan, so this is your heart. Kunwari biphasic na tayo ha. Guys, when we talk of biphasic, dalawang paddles pa magbibigay ng energy. Saan nga tayo naglalagay ng paddles natin? At the right upper sternum, dito. And then ang isa po at the apex of the heart po natin. So that's the proper location po ng ating mga paddles. Pag sinabi natin okay, biphasic, dalawang paddles ang magbibigay ng energy. Now usually kasi, the AHA recommends na pwedeng mag 150 joules ka at pwedeng mag 200 joules. Meaning, pag 200 joules, if the doctor will ask or will tell na or will command, okay, let's defibrillate the patient to 200 joules. Defibrillating the patient to 200 joules, charging to 200 joules. Please clear the patient, paddles on chest. 1, I'm clear. 2, you're clear. 3, everybody clear. Clear. Shocking, boom, shock, 200, paakyat. And then yung 200 dito din pababa. So a total of 400. What's good about this is that it won't cause any burnt myocardial cell. So mas safe talaga siya pag biphasic. Kaya nga pag ang hospital nyo guys, ang ginagamit is biphasic, malamang na-check na po kayo ng DOH. Pero pag hindi pa kayo na-check ng DOH, baka ang naririnig mo pa rin is 360, malamang obsolete yan. And then of course, now for our loving doctors, loving physicians, AHA also recommends that there will be no escalation of joules. If you started with, okay, what? No 150, you're gonna end it at 150. If nag-start po tayo ng 200, we're gonna end it at 200. Okay, so there will be no escalating of joules. Ayan, kung gusto mo talaga na 200 joules as your max, then proceed with, okay, the maximum joules na po. Then, okay, depende din kasi if you're going to follow AHA, or simply you're going to follow your own protocols po sa hospital po natin. Because I cannot blame the hospital. Kasi 'di ba matagal na po sila sa serbisyo. And lahat ng protocols po nila, they are absolutely effective. Okay? So we cannot change your protocols that has already been established for so many years. So hindi na natin guguluhin 'yon. Pero ang sabi lang ni AHA, never escalate joules. If nag-start po tayo ng 150, you're gonna end it at 150. Pag 200, simply 200 lang. So never escalate joules. So usually ang naririnig po natin, kunwari lang ganito. Gamit tayo ng DART sims. Kunwari nakita po natin ventricular fibrillation. Okay, this is a sample protocol po. With American Heart Association, there are 4 ways for us to identify an ECG rhythm or reading rather. Number 1, you tell me the heart rate to be followed by the ECG rhythm, and then you tell me the P wave to be followed by the QRS. So let's apply that. The heart rate here is 0. The rhythm is chaotic. There's no P wave, there's no QRS. So therefore, the patient here is suffering from ventricular fibrillation. And that also means na ang client po natin is suffering. Gagawin natin dito. Guys, in the American Heart Association protocol, di ba? Defibrillation, di ba? Or ventricular fibrillation, sounds like defibrillation. However, it takes time pa rin kasi para mag-ready po ng defibrillation natin or defibrillator. So meaning to say, since free naman po ang high quality chest compression mo, we usually begin with high quality chest compression. So nagko-compress na dyan. And then, sasabihin din po ng doctor po natin, ng our loving physicians na sasabihin nila, okay, let's defibrillate the patient, charging to 200 joules. Ayan. So, dapat si nurse gaganito din. Sasabihin niya, uulitin niya lang din. Defibrillating the patients. Medyo maingay po ito. I-lower na lang po ang volume po natin. Okay, for sure hindi niyo ako narinig doon kasi medyo maingay siya. Ang sination, paddles on chest. 1, I'm clear. 2, you're clear. 3, everybody clear. Clear. Shocking shocks delivered. Please resume high quality chest talaga na ang compression po natin. Kasi sayang time is critical. Ano nga ang sabi ko, pag 5 minutes na nawala ng oxygen, brain damage is possible. Pero pag 10 minutes po na nawala ng oxygen, brain damage is irreversible in nature. So, delikado nga. Continue with our discussion na. Your AED naman po, this is also a basic one. Biphasic po ang AED natin, kaso this is a walking and talking device because this is the automated external. Ayan, external acute defibrillator po natin. So we have the manual. Make sure it's biphasic, and then we have the AED also. Making sure na, of course, AED naman talaga is biphasic in nature. Na, ayan. So for sure, nakakita na po at nakagamit na po na yung mga ano din natin, yung mga AEDs po natin. Okay? Ayan. Kamustahin ko nga si Ma'am Oliva. Hello, Ma'am Oliva. At parang the same kayo ng name ni Sir Peter.
Father ko po siya.
Hindi. Okay. So tatlo kayo. Tama ba ako? Si Ma'am Bienvenida Oliva. Tama ba? How are you related to Mr. Peter Manuel? Kasi Miss Phyllis Oliva. Ma'am Phyllis Oliva, father mo si Doc Peter. Tama ba?
Yes po.
Tapos, kaano-ano mo si Ma'am Bienvenida?
Wala po.
Okay, okay. Akala ko kasi family tree tayo nandito. Sorry. Medyo madami-dami. Okay, ito si Main. We pump Main. Kaano mo si We pump Main? Charot. Okay, so right now, nasa 25 pala tayo. Nice, nice. Okay, so let's proceed na po. Ayan. So in attaching, okay, your electrodes po, ganito yan. Kasi pag monophasic, and then we have the biphasic defibrillator po natin. Pag monophasic, guys, na ito yung mga W, 'di ba? White, black and red. This is for monophasic. The white, black, red. Pag nakikita mo pa rin sa electrode right side and then black on the left side, tapos ayan, over red, that's monophasic. However, hindi na po ginagamit. At pag biphasic po ang ginagamit, green. So red, yellow, and green. Red on the right side, and then, okay, that's biphasic in nature. So this is the ideal. Ito dapat yung ginagamit natin ngayon para hindi po mas sunog ang myocardial cells po natin. Okay po? So again, if the colors na ginagamit po for the electrodes will be red, yellow, and green, updated po yan. Walang problema. Na-check po ang hospital po natin. Okay, let's proceed na po sa ating ECG paper po. With your ECG paper kasi meron tayong tinatawag na big boxes and small boxes. Nasaan ba si big box? Ito, big box to. Yan, big box yan. Yan na. That corresponds to what? No points yan. Sir, question, bakit 0.20 seconds po ang nire-represent ng isang big box? Kasi kung i-dissect po natin, i-zoom in din po natin, a one big box, okay, seconds po. So meaning to say 0.0, ayan, 0.04 seconds times 5, ayan, is equal to, okay, 0.20 seconds po. Nakuha po ba? So ulitin ko. Ang isang big box po, that corresponds to 0.20 seconds. Now, sir, question. Bakit siya naging 0.20 seconds? Because sa isang big box, guys, meron po tayong 5 small boxes. And, okay, each, okay, small boxes that corresponds to 0.04 seconds. So, 0.04 times 5, a total of 0.20 seconds. However, that's not our focus today. Ang hindi po pag-count ng box ang focus natin, but rather, for us to analyze ECG in a matter of 3 seconds only. 3 seconds lang po tayong mag-analyze ha, kasi time is critical and ayaw po natin na madali ang client natin. Kasi hindi po natin alam kung ano yung na maiiwan ng client po natin. What if siya pala ang breadwinner ng family? Na? So, na-slip lang siya sa mga kamay po natin. Kawawa naman. Na? Ayan, or yeah, siguro kasi I don't believe na sa saying na everything happens for a reason. Kasi 'di ba, that okay, ano kasi, that motto in life is actually parang it's a big denial. Like for example, kaya namatay kasi ayan, may rason ang Panginoon. Or let's say na fail ka sa exam no. Ayan, nag-fail ka today, sasabihin mo naman na everything happens for a reason. Tapos nag-fail ka na naman tomorrow, so everything happens for a reason na naman. So simply, you're afraid of, 'di ba? Rejection, no? And it's really a form of denial. Kaya I really hate that motto. Well, na failures are part sa life po natin. And with failure kasi, it will make you stronger. No? Ako kasi I really believe na through pain we gain. 'Di ba? Sige po. So we have the waveforms and then we have the complexes. So we have the atrial depolarization. We have the ventricular depolarization, then we have the ventricular repolarization. Now, just simply, okay, by looking po at the illustration, guys, masasabi mo na, okay, this represents contraction. Okay, this represents relaxation. Sulat ko lang muna ha. So we have the P wave. Meron po tayong P wave. Next to P wave, guys, we have the Qrs Complex. Next to Qrs Complex po, we have the T wave po natin. Okay, pag sinabi po nating P wave, alam niyo ba that your P wave that represents na atrial, ayan, depolarization. Depolarization. Guys, pag sinabi ko ng depolarization, that means contraction. So meaning to say, before talaga mag-start ang ECG po natin, kailangan talaga mag-contract nila. Huwag muna relax, contract muna. Kasi after contraction, there should be relaxation. Contract, relax, contract, relax. Hindi kasi pwede na puro contraction lang. Kawawa naman ang heart po natin. Baka magkaroon ng heart failure. No? Kasi nag-fatigue. No? Like puro contract, 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 wala na pong relax, relax. Meaning to say, your QRS, guys, this represents what? Atrial, ayan, repolarization. Pag sinabi po nating repolarization, this means the what? Na the relaxation ng heart po natin, to be specific, ng atria. Na? Ayan, next. Are you aware also that your QRS complex, this represents, if nag-relax po ang atria dyan, dito din po mag-start na mag-contract si ventricles po natin. So this is the start of your ventricular depolarization. So meaning to say, your QRS complex represents, okay pa, we have atrial repolarization and then we have the ventricular depolarization. Now, how about for your T wave? Alam niyo ba na doctors, nurses, medtechs, and midwife that your T wave represents what? Ventricular repolarization. So repolarization, meaning to say, the relaxation ng, ventricles po natin. So we have the P wave, we have the QRS, and then we have the T wave. Guys, meron akong trivia. What if may nakita kang U wave? Alam niyo ba that your U wave that represents hypokalemia? This represents hypokalemia. And are you aware that your U wave represents the what? The Purkinje fiber, ayan, relaxation. See? kung nag-relax pa ang Purkinje fiber mo, tapos balikan mo yung firing rate niya, which is 20 to 40. So, grabe nga talaga ang bradycardia dito. Kaya nga ang technique ko dati, hypokalemia. Kasi if patient, bumaba po ang kanyang potassium level sa heart niya, or sa body niya rather, then that will represent a U wave. And then U wave that represents a what? A very slow heart rate po. So, bradycardic nga ang patient po natin dito. Ayan. Once in a while, mag-on po ako ng ng video ko. Kasi para at least makita niyo naman yung speaker niyo. Ayan. Kasi medyo bumabagal lang naman siya kanina, pero mas improved na po ang internet po natin as compared kahapon. So, pasensya na. Naging okay lang yung internet ko kahapon. Nung hapon na din, nung nag-hosting na ako kay Dr. Ted. I honestly na starstruck din ako kay Dr. Ted, na ayan, aside sa, 'di ba, well-known talaga siya na speaker like sa ABS-CBN, sa GMA. Nakikita ko lang talaga siya doon. And that was the first time na nag-interact po kami. And mabait siya. And then siguro sa grabe na ng experiences niya, mas doon ako napabilib talaga na ayan, sige po. Kaya for me, experiences will always be the best na teachers talaga in life, na kaya we need to savor na, and we need to 'di ba dapat i-keep, dapat na i-treasure dapat yung mga experiences natin, kasi grabe pala pag i-share na po natin siya sa ibang tao, na ayan, doon ako na amaze talaga. Okay, so we have the P wave, we have the QRS, we have the T wave, and then we have the U wave po natin. So, sir, let's begin na po. Now, in order for us to analyze ECG, ayan, we will be analyzing ECG now. To analyze ECG, number 1, you tell me the heart rate. To be followed by, you tell me the rhythm. Next, you tell me the P wave. And lastly, you tell me the QRS. Complex po natin. So again, here are the 4 steps for us to identify the ECG later. Number 1, you tell me the heart rate. Pero may ipapamemorize ako sa inyo ha. You memorize this. 300, 150, 100, 75, 60, 50, 40, 30, 20, and then 10. I-memorize po natin yan by heart. It's 300, 150, 100, 75, 60, 50, 40, 30, 20, and then 10. Sige nga. Kayo nga lang guys. Sige po, start.
300, 150, 100, 105, 60, 50,
40, 30,
30, 20.
Ayan, sige nga, walang papaya. Sige daw. 5, 6, 7, start, go.
300, 150, 100, 75, 60, 50, 40, 30, 20, 10.
Alright. I-memorize po natin yan ha, kasi mamaya na makukuha po natin ang heart rate ng isang client if i-memorize po natin yan. Next. For the rhythm naman, pag the same po, ang distance nila, ang tawag doon irregular. Next, pag not the same naman po, not the same distance, ang tawag natin doon irregular rhythm. Guys, what's the other term for irregular? It's the arrhythmia. 'Di ba? Arrhythmic na ang rhythm po natin. Pag the same ang rhythm nila, it's what? It's regular. Now, ano bang i-check po natin to determine for the rhythm? Of course, the distance between the P is to P wave and then the R is to R wave. You're going to check their distances. Pag the same ang distance ni P is to P, is to P, is to P, the same distance, the same distance, the same distance, meaning to say it's regular. Pag hindi na po the same ang distance nila guys, ang tawag doon irregular, meaning to say may arrhythmia na po ang patient po natin. Next, we have the P wave. Now, for the P wave naman po, you can always determine whether if it's the sinus 1, if it's an atrial, or if it's ventricular. Now, if the P wave po is clear and it's upright in nature. Next, if that is unclear, and if it's buried in nature, ano kaya ang nangyayari? Now, what if absent po ang what? No, ang P wave natin and purely QRS? Then, ano ang tawag natin na sa ating ECG? Guys, everybody say clear and upright.
Clear and upright.
Thank you so much. I love this group, no? Very interactive. Meron kasi kaming one time na may training kami na halos ako na lang po ang nagsasalita. Charot lang. Never pa naman nangyari 'yon, no? Kasi gusto ko talaga may interaction dapat. Pinipilit ko talaga silang sumagot, na. Ayan, so we have the clear and upright. Pag sinabi po natin clear and upright, this is sinus. Ayan, now if that's clear, unclear rather, and buried in nature, ang tawag po natin atrial problems. Now, what's good about, no, sa sinus po at saka sa atrial, madedetermine mo pa lang yan, lalo na sa heart rate po nila. Why? Kasi pag sinus po, it's less than 150. Pag greater than 150 na po, dyan napapasok ang tinatawag na atrial problems po natin. Ulitin ko ha. Pag less than 150, yes, meron pa rin tayong sinus tachycardia. However, ang boundary niya po will be 150 lang. Pag greater than 150, dito na po pumapasok ang atrial tachycardia. Example will be the supraventricular tachycardia or the SVT. Diba? Ayan, or the atrial tachycardia po natin or the narrow complex tachycardia. Yes, you heard me right. Because I have this instructor po from UST by the name of Dr. Dilima. Ayan, nung nag-ano kami sa kanya instructorship po, ang sabi niya, it should be pronounced supraventricular tachycardia and not supra. Because ideally pala, na pag na-pronounce po tayo ng Supreme Court, it should be Supreme Court din pala. And sabi ng kapatid niya na si Laila de Lima. Yeah, doctor and attorney pala yung ano nila. So yun lang, yung nakasamahan po namin siya sa sa isang summit po for the instructorship. And then yun, nagturo din kami sa St. Luke's na inadapt din ng St. Luke's si supraventricular tachycardia or the narrow complex tachycardia or the atrial tachycardia. Now, we have the absent. If that's absent po, wala po tayong P-wave. If that is purely QRS, then ang tawag po natin dito, it's the ventricular. So we have the ventricular, okay, problems po. Guys, the deadliest ba pag ventricular? Yes. The deadliest one. Pag sinabi po nating ventricular na, okay, dito na pumapasok si ventricular fibrillation, si pulseless ventricular tachycardia, na kung saan they fall sa tinatawag na arrest setting. Tatlo kasi yan eh. We have the diba, pre-arrest, meron din tayong arrest, meron din tayong post-arrest setting. Usually, mas ma-action talaga sa arrest setting. Ito na yung, diba, code blue to ER bed 1, please. Code blue to San Lorenzo Ward bed 1. Code blue to ICU bed 1. Kasi when we say code blue, that means cardiopulmonary. May problem sa heart, may problem din sa lungs ni patient. Kaya cardiopulmonary resuscitation ang code blue po natin. Meron din kasing mga code white, code black, code brown, code orange, code red. Ang daming mga codes po. Depende sa hospital. Okay? Ayan. So we have the P-wave, guys. Pag sinabi ko later, the P-wave is clear and upright. Malamang it's sinus. If that's unclear and if that's buried in nature, ang tawag po natin doon atrial problem. Next, we have absent, and if that's purely QRS, and therefore that's your ventricular problem, which are the deadliest one, the scariest among, okay? Ayan, diba, sa sinus, sa atrial, mas nakakatakot talaga si ventricular problem. Okay, let's have the Qrs complex. Now, for the Qrs kasi, pwede siyang normal, pwede siyang the narrowed one, or pwede rin po siyang the widened. Okay, 1. Guys, if that's narrowed, then this is really common to patients who are suffering from atrial tachycardia. Or, pag ang patient po natin may SVT or the supraventricular tachycardia po natin. Next, pag sinabi naman po nating widened, malamang, ayan, it's really common na sa patients po who are having ventricular tachycardia. Ventricular. Sulat po natin. Ayan, ventricular. Ayan, tachycardia po. Tachycardia. So normally kasi, ang QRS mo, pag ganyan, it's normal. Diba? Pag ganyan naman, sobrang narrowed. Ayan, pag widened naman, ganito ang itsura niya. Kaya nga 'di ba ang tawag po natin sa widened para siyang sore thumb. Guys, show me your thumb. Show me your thumb, 'di ba? Ayan, this is your thumb. Pag dikit-dikitin po natin yung thumb natin at sore siya at 'di ba namamaga, then ang tawag doon is your widened Qrs. And usually kasi pag ventricular tachycardia dalawa yan eh. Pwede siyang monomorphic and then pwede po siya ayan, proceed na po tayo. So again, paano nga ulit yun? So number 1, you analyze no for the heart rate of the bahay ka 300 150 175 naman you check your distance between the P wave and the P wave, the P wave and the P wave. What if walang P wave? Eh di sa R tayo, 'di ba? QR. R. Pag the same ang distance nila, lalo na pag may VTAC ang client, monomorphic, 'di ba? Meaning regular pa rin 'yon. Pero pag hindi na po no regular or pag hindi na po the same ang kanilang distance, ang tawag natin doon na sinus arrhythmia, 'di ba? Or baka may mga dysrhythmia nang nangyayari. Ayan, next po for the P wave. Ito, huwag niyong kalimutan 'to kasi masasabi at mas mapapabilis pang buhay po natin, especially sa pag-analyze ng ECG, no? Pag i-master po natin 'to. Ayan, if the P wave is clear and upright, it's sinus. If it's unclear and buried po, it's an atrial problem. Tapos pag absent, if that's purely QRS, ang tawag po natin ventricular problem, the deadliest and the scariest po. For the QRS naman po guys, tatlo yan. It can be a what? Normal one, a narrowed one. Narrowed one is very common po sa ating atrial tachycardia or commonly known as the SVT or the Supraventricular Tachycardia. Next, we have the widened one also, which appears to be na parang sore thumb, 'di ba? Pag dikit-dikit mo yung thumb po natin, and it's the ventricular tachycardia. So guys, na before po tayo mag-proceed sa formal lecture po natin, let's have our 10-minute break. Na you drink your coffee, let's have the bladder break first para para hindi masyado tayo ma-drain. Okay po? You hydrate ha, 10 minutes po. So be back at exactly 9:15. We will resume at exactly 9:15 a.m. So bye for now. Na mag-breakfast ang dapat mag-breakfast. Sige po. I'll be playing a video ha. Yung video na hindi masyado na-appreciate kahapon kasi wala pong ayan. Pangit po kasi ang internet kahapon. Alam ko kasi dito tayo nag-stop eh. Oh. I-play ko lang siya.
Reversible chest rise. When using a bag mask device, whether there are 2 providers delivering breaths or just one, be careful not to press too hard on the mask, which could push the patient's jaw down and obstruct the airway. There are several possible indications for insertion of an advanced airway. These include difficulty providing effective bag mask ventilation, patients with actual or potential airway compromise, particularly with long transport times, or the need to isolate the airway. With careful attention, trained healthcare providers can use an advanced airway to safely provide ventilation that is as effective as bag mask ventilation. Advanced airway devices offer many advantages. These include isolating the airway and reducing the risk of aspiration and gastric insufflation. After inserting an advanced airway during CPR, providers should deliver 1 breath every 6 seconds without interrupting chest compressions. Unfortunately, insertion of some advanced airway devices, like an endotracheal tube, may require interruptions in chest compressions that last longer than 10 seconds. These interruptions may reduce survival rates for VF arrest patients. It should also be noted that there is no evidence that advanced airway measures improve cardiac arrest survival rates in either in-hospital or out-of-hospital settings, so providers must carefully consider all these factors before performing the intervention. There are other advanced airway devices that healthcare providers can often insert without interrupting chest compressions. These include supraglottic devices, such as the laryngeal mask airway, the laryngeal tube, and the esophageal tracheal tube. Healthcare providers who use advanced airways within their scope of practice must maintain their skills by using them frequently. The American Heart Association recommends that you become familiar with a variety of devices, but master one primary method of advanced airway control. If you're unable to establish an advanced airway, continue ventilation with a bag mask device. The laryngeal mask airway is a supraglottic airway device that healthcare providers can insert without visualizing the glottis. In addition, it can be inserted during CPR while chest compressions continue uninterrupted. This makes training easier and insertion more reliable. The laryngeal mask airway is a tube with a distal inflatable cuff shaped like a mask that is placed in the patient's hypopharynx. Place the laryngeal mask airway in the open mouth with the opening of the mask facing the patient's tongue. Advance the device to the back of the tongue. In a smooth motion, use your index finger to press the laryngeal mask airway against the roof of the mouth and guide it downward. Continue advancing the device until you feel resistance, which indicates the distal end of the tube has reached the hypopharynx. Withdraw your finger and inflate the mask. Once inflated, the laryngeal mask airway will center itself in the mouth. If placed correctly, oxygen will flow through the lumen of the device and into the trachea. The laryngeal tube is a supraglottic device that can be inserted in an unconscious patient. Providers can insert the device during CPR while chest compressions continue. The device can also be inserted without visualizing the glottis. The laryngeal tube is a single lumen device with two cuffs inflated through a single inflation port. The distal tip of the slide into a collapsed upper esophagus reduces the likelihood of tracheal insertion. When the tube enters the esophagus, you should feel resistance. Inflate the cuffs with a single syringe. The esophageal tracheal tube is a supraglottic device that providers can insert during CPR without interrupting chest compressions and without visualizing the glottis. The esophageal tracheal tube is made up of two lumens permanently joined. Each tube can be used to provide oxygenation and ventilation, depending on how it's inserted. The longer blue tube, marked with a number 1, provides ventilation through 8 small side openings of the lumen in the pharyngeal section. The shorter, clear tube, marked with a number 2, provides ventilation directly through the lumen to the end of the tube. Once the tube is in place, use the large blue syringe to inflate the pharyngeal cuff through the port labeled number 1. Then use the smaller syringe to inflate the distal cuff through port number 2. The distal tip of the device will rest in either the esophagus or the trachea. If the tube rests in the esophagus, which happens most frequently, the cuff blocks airflow in and out of the esophagus, and ventilation occurs via lumen number 1 and through the small side openings into the trachea. If the tip of the tube comes to rest in the trachea, however, the rescuer can use lumen number 2 to deliver ventilation directly into the trachea. Caution: it's critical to confirm the proper placement of the esophageal tracheal tube, because if ventilation is delivered to the incorrect lumen, it will prevent adequate oxygenation and ventilation and result in severe hypoxia. Incorrect delivery of ventilation to the esophagus will also produce gastric insufflation that will complicate ventilation. The endotracheal tube was once considered the optimal method of managing the airway during cardiac arrest. However, intubation attempts by unskilled providers or by providers who use it infrequently can produce serious complications, such as trauma to the oropharynx, incorrect placement in the esophagus or right main bronchus, and prolonged interruptions in compressions and ventilations. Despite the risks of intubation in inexperienced hands, there are many benefits to endotracheal intubation. These include keeping the airway patent, allowing suction of the airway, speeding the delivery of high concentrations of oxygen, providing an alternative route for some drugs when intravenous or intraosseous routes are not available, and when using a cuff, potentially protecting the airway from aspiration. The endotracheal tube is a single clear lumen with a single cuff. To insert the endotracheal tube, place the patient's head in the sniffing or neutral position. Insert the laryngoscope blade into the patient's mouth. Lift the laryngoscope vertically up and away to expose the vocal cords and glottic opening. insert the endotracheal tube directly between the vocal cords and into the trachea until the cuff passes the cords. Once the endotracheal tube is in place, inflate the cuff and attach a waveform capnography monitor to confirm proper tube placement. When choosing to use an advanced airway, you need to be confident that it is inserted correctly and that you're providing effective ventilation while avoiding excessive ventilation. Watching for chest rise, checking for bilateral breath sounds, and listening for gurgling sounds coming from the stomach can help you confirm the placement of an advanced airway. Beyond these clinical assessments, there are several devices that can help you determine whether you have inserted the airway correctly. Waveform capnography monitors how much carbon dioxide is exhaled by the patient. The American Heart Association recommends using waveform capnography to confirm and monitor the correct placement of an endotracheal tube. Scientific studies have not yet validated waveform capnography as a method of confirming proper placement of supraglottic airways. However, effective ventilation through these airway devices should produce a capnography waveform. A normal end-tidal CO2 waveform looks like this. The measurement of the amount of end-tidal, or exhaled, carbon dioxide can be shown as a waveform, where the carbon dioxide level goes up when we exhale and falls back to zero when we inhale. Even when healthcare providers are properly ventilating the patient, chest compressions will produce a low end-tidal CO2 reading because even the best CPR produces cardiac output and pulmonary blood flow that's about 25 to 30% of normal. In contrast, ROSC can cause an abrupt increase in end-tidal CO2. Waveform capnography devices that display both a waveform and a number will give you the most comprehensive information. Connect the monitor between the advanced airway and the bag or ventilator. Waveform capnography provides a graphic demonstration of the carbon dioxide exhaled with every breath. Humans with healthy lungs have a characteristic waveform that is divided into 4 phases that occur during inspiration and expiration. When the patient first begins to inhale, the curve falls sharply to 0. As the patient continues to inhale, the reading on the monitor should remain at 0. When the patient first exhales, the initial portion of the breath consists of the air in the dead space from the breathing tube and the trachea. As air from the alveoli begins to empty into the circuit, carbon dioxide levels start to increase. This is shown as an upward deflection at the beginning of the exhaled carbon dioxide curve. As exhalation continues, carbon dioxide continues to pour out of the lungs until the next breath is initiated. The highest value in the curve is called the end-tidal CO2. For patients with normal perfusion, an end-tidal CO2 reading of less than 35 millimeters of mercury indicates hyperventilation. A reading of more than 45 suggests hypoventilation. In the patient with adequate circulation, the key uses for waveform capnography include the placement and monitoring of an advanced airway and the management of ventilation support. In cardiac arrest patients, waveform capnography reflects the effectiveness of chest compressions during CPR, and a sharp increase in end-tidal CO2 signals the return of spontaneous circulation. The higher the end-tidal CO2 pressure, the higher the cardiac output is during resuscitation. An end-tidal CO2 of less than 10 millimeters of mercury suggests that the cardiac output is insufficient to achieve ROSC. If the CO2 readings are low during resuscitation, the team should optimize CPR quality by minimizing interruption in compressions, delivering compressions at a depth of at least 2 inches and at a rate of at least 100 but no more than 120 compressions per minute, allowing complete chest recoil and avoiding excessive ventilation. Sudden changes in the waveform should trigger immediate reassessment of the patient. When the waveform jumps up during resuscitation, this may indicate ROSC. A sudden drop in waveform of 20 points or more could indicate a sudden, severe decrease in cardiac output that might be caused by a pulmonary embolus, acute blood loss, or a life-threatening arrhythmia. A decrease to 0 indicates no gas exchange or no carbon dioxide delivery, such as occurs with a displaced endotracheal tube, or the sudden stopping of blood flow, such as occurs with ventricular fibrillation. A rising baseline in the end-tidal CO2 waveform suggests that carbon dioxide is re-entering the side stream sampler during the inspiratory phase of ventilation. This reading might indicate that the patient is rebreathing carbon dioxide. This waveform has a prolonged phase 4, or inhalation, section. This suggests that there's air entering the trachea beyond the entryway that's being monitored. This happens if the cuff on the tube is deflated or if the tube is too small for the patient. In both arrest patients and post-cardiac arrest patients, ventilation and perfusion must be optimized to prevent lung injury, cerebral ischemia, and cardiogenic shock. The use of waveform capnography can dramatically enhance your ability to manage cardiopulmonary patients. Another type of CO2 detector, the colorimetric end-tidal CO2 detector, simply changes color when it detects CO2. One additional confirmation device is the esophageal detector device, or EDD. The EDD is a bulb that providers compress and attach to the endotracheal tube. If the tube is in the esophagus, the bulb will not re-expand and fill with expired CO2. An alternative model is a large aspiration syringe attached to the tube. If the endotracheal tube is properly placed, providers will have no difficulty retracting the plunger. Esophageal placement will prevent plunger movement. Airway skills are fundamental to successful ACLS. Proper training, frequent practice and use, and logging both successes and complications can help build your skills and lead to more comprehensive, successful patient care.
Okay, sa discussions po natin kanina, so we have the atrial depolarization, which represents your P wave, or your P wave represents atrial depolarization. Next, we have the QRS also, that represents dalawa. We have depolarization, and then we have the repolarization. So we have the ventricular depo, which is your, di ba, the contraction of your ventricles. However, kasi kakakontract lang ng atria mo, so kailangan niya ding mag-relax. So dapat meron tayong atrial repolarization. And then lastly, we have the ventricular repolarization, which represents the relaxation of our ventricles. And that's your T wave. Ayan. Okay, let's have the ano na po, na, to determine the heart rate of the patient. Guys, alam niyo ba, para pag mag-determine po ng heart rate ng client, ayan, we need to try na natignan po ang QRS that falls on a straight line. Ulitin ko ha. Maghanap daw tayo ng QRS na nag-fall sa straight line. Sir, saan ba ang straight? Ito oh. Mga straight line po natin sila. However, kasi sa panahon ngayon, mahirap na pong i-identify kung straight ba talaga siya or what. Na? So, ayan na. Wait lang. Okay, maghanap po tayo ng QRS. Meron ba kayo nakikita, guys, na nag-fall sa straight line? Meron po. Ito, sir, oh. Ayan, nag-fall sa straight line. And then mag-count po tayo up to the next QRS na magfo-fall. However, kasi, ayan, ito yung next QRS mo. Saan siya nag-fall? Eh, dito siya magpo-fall. Okay po? Nakuha. So, meaning to say, this is your first straight line and this is the second straight line po natin. Because we need to determine from, the first QRS up to the next QRS. Ito kasi yung QRS mo, QRS. QRS. Okay? Ayan. So, paano ba mag-count? O, take a look ha, at saka pakinggan ng mabuti para hindi tayo malito later. So, mag-count daw tayo, ayan, na hindi starting sa first line, but rather, dito na tayo, na sa red. Ito, red, 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 and then dito din. Isasama natin sa counting yan. So, paano mag-count, sir? 300, 150, 100, 75. O, tignan natin ha. Ang next QRS mo daw falls between 100 to 75. So, pwede siyang 78, 79, 80, up to 100. Ang importante, yung next QRS mo falls between 100 and 75. Meaning normal ba ang ating heart rate? Yes or no? Yes, normal po siya. Ulitin ko. Sir, paano ba mag-determine? You look for a QRS that falls on a straight line. This is the straight line. And ito yung next po natin. na up to the next QRS. So mag-count tayo dito, 300, 150, 100, boom, 75. So ang QRS po natin na next ay napapagitnaan ng 100 to 75. So more or less po ang kanyang heart rate is between 100 to 75. So pwedeng 80, pwedeng 90, pwedeng 100. Na? Pero ito kasi, for sure, nasa mga 80 lang yan, nasa mga 90 lang yan. Kasi ang sabi niya, 100 to 75. Pero hindi siya greater than 100 para masabi nating tachycardic. Na? And then, yeah, na basta between 75 to 100. Hindi rin kasi natin siya pwede masabi na pag less than 75, bradycardic. Hindi. Kasi diba 60 dapat na and below para masabi natin bradycardic. So again, normal ang heart rate natin dito. Guys, himay-himayin na natin. Aside from, determining the heart rate, you tell me the rhythm. Tignan mo ang distance between the P's to P. Ayan, P wave, P wave, P wave, P wave, P wave, P wave, P wave. I-connect mo. Diba the same ang distance nila? Kahit hindi mo i-connect, kahit tignan mo lang with your naked eye, na without using a ruler, the same ba ang distance? Yes. So meaning regular ang rhythm natin dito. Next, you tell me the P wave. Is the P wave clear and upright? Tignan mo. Yes, it's clear and it's upright. It's clear and it's upright. It's clear and it's upright. So malamang regular ang heart rate po natin. Nasa, let's say, sabihin natin 80 ang heart rate ni patient. Wait lang ha, isulat natin. 80 ang heart rate ni patient. Yes, irregular po ang kanyang rhythm. And then you tell me the P wave. Malamang it's sinus. How about now for the QRS? Is it clear and is it narrowed ba? Is it normal? For sure, this is normal in nature. Ang kanyang QRS. So therefore, anong tawag dito? It's sinus. However, normal ang kanyang heart rate. So ang tawag dito, it's normal sinus rhythm. Okay po ba? What if bibigyan kita ng let's say ang heart rate niya is 55. Tas the same pa rin, malamang na it's sinus bradycardia. Basta i-determine mo muna ang kanyang P wave, whether if it's clear upright para masabi mong sinus, atrial, or ventricular. Tapos balikan mo ang kanyang heart rate to know whether if it's tachycardia or bradycardia. Let's say ganito pa rin ang scenario. Tapos ang kanyang heart rate is 110. And then ang tawag doon, sinus tachycardia. If ganito ang itsura, tapos ang kanyang heart rate is 35, malamang it's sinus bradycardia. If within the normal range po ang kanyang heart rate, then it's your normal sinus rhythm po. Na-identify po ba? Did you get me po ba? Ayan. Can I see a heart reaction po sa ating Zoom room? Ayan. I hope hindi po tayo, ayun. Thank you so much. Ayan. I hope na hindi po tayo ma-hack ulit. Diyos ko Lord, yung nangyari kahapon, di ba? Biglang pumasok ang ang mga from Thailand. Last time din, nag-free seminar. Ako naman nag-free seminar. Biglang may pumasok na mga from Saudi Arabia. Diyos ko po, nakakatakot. Tapos biglang nanggugulo sila. Para silang mga alien, guys. Ganun talaga. Kaya parang sanay na ako sa mga ganun. Even sa school din namin, may event kami. Tapos pinakalat yung Zoom link. Aba, Diyos ko, no? As in like, grabe, para kaming nag-United Nations, like, ay, iba-iba talaga ang pumasok. Like, mga 100 plus sila. Ginulo lang nila kami lahat. Okay, sige po. You tell me if it's regular or irregular rhythm. Sige nga. Ayan, tignan natin sa ating ECG strip dito. Is it regular or irregular? Guys, regular, irregular. The same bang distance nila? Yes, tignan mo ang P, P is to 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 P. The same distance, yes. Connect, 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 connect. The same distance, yes. R, how about the R? The same ang distance ng R nila. Kahit walang ruler. Pag the same ang distance, ang tawag doon regular. Pero pag hindi na po the same ang distance, ang tawag natin doon irregular. Kasi may arrhythmia na po ang patient po natin. Okay. Sige nga. In determining the P wave po natin, guys. Ito, this is an example of a clear and upright. Clear and upright P wave, clear and upright, para masabi po natin na sinus. Pag hindi na po yan clear, anong tawag natin? Atrial problem. Now next, more of that pa later. Sige lang. Oh, yung QRS po natin. If that is widened, ganyan ang itsura niya. If that is narrowed, no, na very common sa SVT, ito naman very common to sa VTAC po natin. Lalo na sa mga monomorphic VTAC or monomorphic ventricular tachycardia. And next, we have the normal QRS po natin. So again, no, here are the basics po na in understanding and in determining our ECG. So sige, you tell me if it's regular or irregular. Sige nga, I'll be showing you an ECG po. Regular or irregular lang sasabihin nyo ha. Regular, irregular?
Regular.
Great, it's regular. Guys, ang titignan lang natin ang distance ha. Baka kasi ang titignan nyo po ay yung nila, yung height nila, yung isa pandak, yung isa matangkad, yung isa pandak. No, it's the distance. Ayan, example. O ito, tell me if it's regular or irregular. Wala pa. Ayan.
Regular.
Okay.
Irregular.
Regular.
Ayan, great po. This is an irregular one. An irregular rhythm po natin. An example of a sinus arrhythmia. Tignan po natin to. So guys, upon looking sa distance po niya, this is regular. This is regular with, diba, a bird, no? Bird ang kanyang, what? Ang kanyang QRS. Bird ang kanyang P-wave rather. Pero ang kanyang QRS po, it's what? It's narrowed in nature. Ano yung sabi ko kanina? Pag narrowed QRS, malamang this is an example of a supraventricular tachycardia. Your SVT or an example of your what? No, an atrial tachycardia po natin. Okay? Ayan. Next. Ayan. Yes po. Next po. Tell me if it's regular or irregular. Ayan.
Regular, but it's brady.
Yes. Great po, Doc. So we have here a what? Na regular, but the patient here is suffering from sinus bradycardia. Okay? Ayan, sige. Ayan, ang galing naman ng mga trainees po natin for sure, no? Like mga hustler na talaga. Okay, let's have the first topic po natin known as the sinus rhythm. Guys, when we say sinus rhythm, known as the NSR, diba? Pag sinabi po nating NSR, lahat po ay normal dito. However kasi, ang sabi ng tinatawag na American Heart Association, it won't exclude a patient from developing a what? Cardiac problem. Meaning to say, di porket NSR na siya ay hindi na magkakaroon ng cardiac problem ang patient. Possible pa rin po. So careful pa rin po tayo. We need to monitor pa rin the vital signs of our patients po. Yun ang pinaka-importante sa lahat. We monitor. Lalo na pag alam po natin may mga cardiac problems si patient. Now, we have the sinus rhythm. The heart rate here is within the normal range. It's 60 to 100. Because if that's less than 60, it's bradycardia. If that's greater than 100, it's tachycardia. Next, we have the rhythm. The rhythm should be regular. Yes, the P waves are clear and upright, followed by QRS, which is normal in nature. Walang problema dito, sir. Kaya ang tawag natin, it's normal sinus rhythm. Next, we have the sinus bradycardia. As for sinus bradycardia, the problem here is, of course, now we have a less than 60 beats per minute. Ito talaga yung problem natin. We have an abnormal, heart rate here of less than 60 beats per minute. Now, sir, kanino ba common ang sinus bradycardia? Letter A's po natin. These are very common to athletes po natin. Aside sa athletes, guys, sa mga taong tulog. Now, kasi sa mga taong tulog, legit na tulog, they will be suffering from sinus bradycardia kasi masyadong relax ng heart nila. Pero sa mga taong tulog-tulugan, malamang tachycardic po yan. Kaya hindi po totoo na sinus bradycardic ang mga taong tulog-tulugan. Ito yung mga kapatid po natin, 'di ba, mga tamad? Tapos pag inuutusan po natin ay nagiging paniki, 'di ba? O maghugas ka ng plato, but ako. 'Di ba, magwalis ka na doon, but ako, no? Diyos ko, mga tamad lang talaga yan. So we have the athletes po and then we have the asleep. Kaya pansinin niyo yung mga tao na like mga athletic talaga. patakbuhin mo ng mga 100-meter dash na parang okay lang sa kanila. Like normal ang vital signs, walang mangyayari. Pero pag ako, patakbuhin mo ako guys ng 100-meter dash, siguro sa 50 meters pa lang, nagkaroon ako ng VFib. Ayan, as in like, ewan ko ba, no? Pag mga strenuous exercises, activities po, I really hate them. Aside sa diabetic, 'di ba? Medyo hingalin lang din ako, no? Ayan. So we have athletes po and we have really asleep, mga taong tulog. Expected po na slow ang heart rate po nila. Now, we have the rhythm here is regular. Yes, the same po ang distance. Ayan, we have the P waves which are clear and upright, na, followed by QRS which is normal. Now, i-check nga natin, sir, kung kamusta ang kanyang heart rate. Sige nga. May nakita ka bang QRS that falls on a straight line? Ito. Tapos, ang next will be dito po. Sige, i-check natin. From the first QRS up to the next QRS, kamusta kaya ang kanyang heart rate? Let's begin. 300, 150. Wait lang ha. So, 300, 150, 175. 60, 50. Boom. 60, 50, and then 40. So, meaning, it's between 50 to 40. Malamang kahit sabihin mo pang 50 yan, no, less than 60 pa rin yan. So, malamang this is a, what? No, a bradycardic po na heart rate ni client. And then, pansinin mo guys, na ang kanyang P-wave po is clear and upright. So, meaning it's sinus. So, if this is sinus, then balikan mo ang kanyang heart rate. Kasi usually, upon looking sa P-wave po natin, madadetermine natin ang first name ng isang Ecg rhythm. Or Ecg reading rather. Para masabi mo na, okay, is it sinus? Is it ventricular? Is it an atrial ba? Na? Ayan, so yun po yung gagawin po natin ha. Ayan, so again, this is an example of a sinus bradycardic client po natin. Now, next po guys, we have the sinus arrhythmia. Everybody say arrhythmia.
Arrhythmia.
Thank you so much. Thank you so much. Ayan, Doc Peter, si ano din po ba? Yung anak niyo po ba ay doktor din?
Yes, sir.
Ay, nice. Family of doctors pala. Ay, I love that. No, amazing ang bahay. Halos lahat ba ng anak mo, Doc Peter, ay nag-doktor po?
Yung isa is nurse and the other one is an intern, medical intern.
Ay, nice, nice, nice. For sure, yung si nurse mo din, Doc, ay magdo-doktor din yan, for sure. Inspired by you.
No, actually, she's working in Australia.
Okay. That's nice, Doc. That's nice. Ayan. From Iriga, Doc, no?
Yes, sir.
Iriga. Nakapunta na kami ng Iriga dati. Maganda ang place nyo. Like, very kalmado ang place nyo. And very nature talaga. I love the entire Bicol. I really love the entire Bicol. Medyo medyo kind of frustrated lang ako last time. And kind of broken-hearted lang ako. Kaya I prefer na na umuwi na lang ng Manila and from Manila, bumalik na ng Davao. Kasi yung nangyari kasi na lockdown, it's a make or break din kasi ng isang relationship. Na pero yeah, I'm really happy na with my decisions na din. So we have share ko lang. We have the sinus arrhythmia. Now with sinus arrhythmia, expected po na irregular po ang rhythm natin dito kasi hindi po the same ang distance ng ating P is to P and R is to R. Now with sinus arrhythmia also, ayan, take a look po sa heart rate niya. There's no problem with the heart rate because it's within the normal range. However, kasi the rhythm here is abnormal. Kasi hindi na po the same ang distance niya. And of course, there's no problem with the P waves, the PR interval, and then the QRS. But the main problem is the regularity po of the rhythm. So again, that's the sinus arrhythmia. So makikita po natin, 'di ba? If we're going to connect the dots po, ayan. So, ayan, panaro na siya ng panaro, no? Ayan. Okay, ayun, panaro na siya ng panaro. So therefore, naging irregular nga po na ang tinatawag na rhythm ng patient natin dito. So ang tawag natin, it's sinus arrhythmia. Next, guys, we have the sinus tachycardia. Now, with sinus tachycardia kasi, what are the possible reasons kung bakit nagkaroon ng sinus tachycardia si patient? Now, to patients suffering from sinus tachycardia, so we have the Fs po natin. Number one, if the patient is suffering from fever. Aside from fever po, we have the fluid loss. Okay. Aside from fever, okay, your fluid loss, we have the fatigue. And or basically baka na-stress po ang patient po natin. And lastly, guys, ayan, letter F for in pain. Ayan, pag may pain po ang patient po natin, pag in pain po si patient, then expected po na may tachycardia talaga. Ako na-experience ko na talaga to. I suffered from abdominal pain. And all the while, I really thought that was an epigastric pain. So I'm expecting na baka nag-angina pectoris na pala ako. Ayan, so di ba, as we all know, di ba, your epigastric pain, di ba, yung mga heartburns po natin, they will try to mimic your angina pectoris. Akala mo nag-heartburn ka, Diyos ko po, nag-heart attack ka na pala, nag-angina pectoris ka na pala. So kinabahan talaga ako that time. And then, of course, pag-check ng heart rate ko, pag-check ng BP ko, as in taas lahat. Lalo na pag in pain pala tayo. So pag nasasaktan tayo, expected talaga na tumataas lahat ng vital signs. So we have the fever, expected po na may tachycardia pag may fever, may fluid loss. When we say fluid loss, if there will be signs of dehydration. Next, we have the fatigue, and then we have the stress, and then we have the pain. Okay po? Expected ang sinus tachycardia po dito. Now, balikan po natin ang slides po natin. With sinus tachycardia, let me correct my slide. It should be 101 to 150 only para masabi nating sinus. Kasi if that's 150 and above, it's already an atrial problem. Pag nag 151, 152, atrial tachycardia na po ang tawag doon. Pero pag 101 to 150, it's still sinus tachycardia. Everything is normal here except for the heart rate. Because the heart rate is beyond what's expected and beyond what's normal. Ayan, ang tawag natin, it's sinus tachycardia. Now, let's try to determine kung sinus tachycardia ba talaga to, sir. Maghanap ka ng QRS that falls on a straight line. Ayan. Ayan na nakita ko na siya. Okay, let's begin counting. 300, 150, 100. Okay? The next QRS falls between 150 to 100. So malamang it's above 100 but not above 150. Kasi pag above 150 na yan, it's atrial tachycardia. So 100 to 150, malamang this is still sinus. Okay po? This is sinus tachycardia. Kung ako magdetermine, okay, the heart rate here, let's say the heart rate is 120. The rhythm is regular. I can see P waves. They are clear and upright, followed by QRS, which is normal in nature. Therefore, the patient here is suffering from sinus tachycardia. Now, before I proceed po sa atrial problem po natin, pakita ko muna na ang mga, ating ECG, reading po natin. Yung mga na-discuss lang po natin muna, Okay, let's begin with the first topic. Okay, tell us something na sa ating ECG po. Ayan, the heart rate here is 70. There's no need for you to check for 300, 150, 100 kasi naka-attach naman po sa cardiac monitor Kaya obvious po, the heart rate is 70. So isipin mo agad, the heart rate is 70, ganun dapat kabilis po na ang po natin. Di ba pag-analyze ng isa, okay, normal ang kanyang heart rate. Sige nga, check natin ang rhythm. The same po ang distance ng P is to P and R is to R. So the rhythm here is regular. I can see P waves. They're clear and upright. Okay, clear and upright. Clear and upright, it's sinus. Followed by QRS, which is normal in nature. Therefore, the patient here is having a normal sinus rhythm. Everything is normal. But then again, di porket normal ay hindi na po i-check ang vital signs. Yung iba, akala po natin ay MGH may go home. Pero iba pala ang ibig sabihin ng MGH, may go to heaven. Kaya nakakatakot pag hindi mo i-monitor ang kanilang vital signs. Next po. So we have the heart rate of the patient here, which is 38. So isipin agad natin, okay, less than 60, bradycardic na to. Ang hihintayin ko na lang is the rhythm and the P wave if that's clear and upright. Now, the what? The rhythm here is regular because we have the same distance po sa ating P is to P and R is to R. And then, try to look po sa kanyang P wave, it's clear and upright. Boom, it's sinus. So it's sinus what? It's sinus bradycardia. Tapos, i-continue natin sa QRS. Malamang it's normal. Okay po? Ayan. So, therefore, this is an example of a sinus bradycardic client. Next. Tingnan po natin ang kanyang heart rate. It's 120. Pero hindi po siya above 150. Kasi pag above 150 na po yan, it's an atrial problem. So meaning, nasa sinus pa rin siya. Take a look po sa kanyang rhythm, guys. Malamang it's regular. Okay, followed by, okay, syempre the P wave here is, ayan, it's clear and it's upright. Yes, makikita po natin si P at saka si T. Si P at saka si T. Kasi pag hindi mo nakita, you're not sure if that's P, malamang it's buried. Then that will be the next problem later po. Na? And then, mapapansin po natin ang kanyang QRS, it's normal. So this is an example of a sinus tachycardic client. Kanino nga siya common? If you have fluid loss, if you have signs of dehydration, if you have fever, may tachycardia talaga yan. If may fatigue and stress po ang client po natin. And lastly, na, pag may pain po na nararamdaman si client. Guys, na pain kasi, na these are verbal reports kasi ng client po natin. These are subjective. Kaya as a nurse, na, as a medical doctor, na we always na check na kung gaano ba, na what's the pain scale ba of our client. Sometimes kasi naalala ko nang duty ako sa hospital, tinatanong ko ang client na, ma'am or sir, on a scale of 1 to 10, how would you rate your pain? Tapos ang sagot ni client, 15. Ay, ang tanga-tanga naman ni mama at saka ni sir. 15 talaga. Wag mo namang sabihan na gano'n. Siyempre, i-accept mo na she's trying to exaggerate the pain kasi siya lang naman talaga nakaka-feel nun eh. We don't go there. We don't need to have that duty just to judge our clients but to accept, 'di ba? The fact na nasasaktan talaga sila. It should be a non-judgmental approach. Kasi some of us na siguro nagsawa na din sa client na, Diyos ko, ang client na to, sinungaling to eh. Gusto niya lang talaga na ano, 'di ba? Tuturo ka na ng mga pain meds, ng mga opioid para sabog-sabog feels. And sometimes naman may naririnig po tayo na mismo si nurse na ay gumagamit po no ng mga opioid, 'di ba? Anong tawag natin sa kanila, guys? If we're going to take the NCLEX, they are impaired. Ang term doon sa kanila is impaired na nurses or impaired medical frontliners pag gumagamit po, no? Let's say yung mga drugs na instead dapat sa client sila na mismo tinutusok na sa sarili nila. Impaired ang tawag doon. Okay? Hindi po addict nurses but rather impaired na nurses. All right, so let's proceed na po sa ating next topic. Okay, as you can see, heart rate po ni patient dito, guys, is normal. Walang problema. However, ang problema ko dito, sir, is the rhythm. The heart rate falls, no? Ayan, sa normal po na level. However, ang kanyang rhythm po is not normal. They don't have the same distance. So, it's irregular. So, nabanggit mo palang irregularity ng kanyang rhythm po. So, ang tawag natin dito, this is what? The sinus arrhythmia. Okay? Sige nga. Try to identify po. Ipakita ko lang ang what? No, ang ECG, tas try to identify. Pwede kayo mag-chat or verbal po na nasasagot. Let's begin. Let's try to analyze your ECG in a matter of 3 seconds only. Start. Guys, this is what? This is what? Okay, sinus tachycardia. Great. Next. Patapusin ko na. That's what?
Sinus rhythm.
Okay, normal sinus rhythm. Great po. Next. this is what?
Sinus.
Sinus. Sinus Bradycardia. Thank you. Next. Okay, so we have sinus arrhythmia. Okay, the sinus arrhythmia po natin. Thank you. Ayan, so apat pa lang po dinidiscuss natin. Haba kayong iba sa inyo, ayan, bigla nang sasagot ng mga first degree AV block, second degree AV block. Wala pa po mamaya pa po yun. Okay, sige, for a while. So we have a lot of causes po for the sinus tachycardia. Pero yung na-mention ko kanina guys, yung mga Fs po natin, yung talaga yung mga pinaka-common po natin. Okay, let's have atrial tachycardia. Let's proceed na po sa atrial problems po natin. Guys, pag sinabi po natin atrial tachycardia or your SVT to or the supraventricular tachycardia or also known as the narrow complex. The narrow, complex tachycardia. Now, we are advancing na po tapos na po tayo sa sinus problem. Ano nga yung sabi ko guys, para masabi natin atrial tachycardia yon, if that's greater than 150 beats per minute. If greater than 150 beats per minute, you are now experiencing mas nakakatakot na, mas advanced, mas higher na po ito na problem. This is atrial tachycardia. With atrial tachycardia po, it is actually expected na 100 and 150 and above po ang heart rate ng patient natin. Sa Manila po, they call this as the supraventricular tachycardia or the narrow complex. Why? Tignan mo naman ang kanyang QRS. It's so narrowed in nature. Okay. The rhythm here, walang problema. It's regular. However, kasi, the problem now is your P wave. Abnormal po ang P wave nito. It's buried preceding to T wave. So malamang this is buried and this is unclear. I-try natin i-differentiate. Guys, di ba tapos na tayo sa sinus tachycardia? Focus ka kay sinus. Clear, This is your T wave. This is P. This is T. This is P. This is T. And this is P. Clear pa and upright. However, pag sinabi ko ng atrial tachycardia, is this T or is this P? Pero sure ako guys na your P wave is buried preceding to T wave. Why? Dahil gutom daw si T mo, kinain niya si P. Ulitin ko Dahil gutom daw si T, kinain si P. Kaya you're not sure anymore if this is T or P. Kaya nga it's unclear. It's buried preceding to T wave. If you're going to compare atrial tachycardia to sinus tachycardia, this is sinus tachycardia and this is supraventricular tachycardia. Tignan mo ang differences nila. Ayan, sa SVT, buried. Dito, it's clear. And this is upright also in nature. Kaya masasabi natin, okay, clear and upright. Na-clear pa siya. Na-analyze ko pa siya na si P, si T, si P, si T. Pero dito, pag atrial is that my T or is that my P? That my P or is that my T? Basta it's buried preceding to T wave and it's unclear. That's atrial tachycardia. Naalala ko lang, I can vividly recall what happened 3 years ago. My father died kasi brought about by motor vehicular accident. And then, andun ako sa Manila that time, biglang nabisaya. Andun ako sa Manila that time. And then, syempre, dapat kasi talaga uuwi ako ng November November 1 dapat yun, November 1. Kasi meron kaming parang mini gathering lang sa Davao with family. Tapos nabalitaan ko na lang na syempre lasing siya, tapos nagmotor, tapos ayun, nag-motor vehicular accident. So syempre andun ako sa Manila, so same day, same flight so when I arrived Davao, mga 6 AM, like medyo sabog-sabog pa ang feeling. Tapos nasa ICU na. Tapos when I got there, I asked the nurse po, sabi ko, ma'am, is my father stable? Tapos sabi pa niya, yes, sir. Tapos parang siyang nagalit na parang siya ang strongest nurse ever. Ayan, tapos parang I was just asking lang naman I was just confirming din kung stable ba talaga. Tapos sabi niya, yes, sir, stable siya. Tapos ganun, pinabagsak. May mga ganun talaga na mga intonation. So ako naman, medyo parang na-pissed off ako pero hindi masyado pina-obvious. Baka kasi estudyante ko sa nursing or estudyante ko. For sure, kung estudyante ko siya, malamang kilala niya dapat ako. Kaso, for sure hindi. Ayan, so yun na. Tapos tinanong ko talaga, the second time around, sabi ko, is my father stable? Sabi niya, yes sir, stable nga ang father mo. Sabi ko, stable pala ang 170 beats per minute ang kanyang heart rate. The rhythm is regular. The P waves are buried preceding to T wave followed by a narrowed QRS. Ma'am, feeling ko ang father ko, ma'am, nagkaroon siya ng SVT or the Supraventricular Tachycardia or the Atrial Tachycardia. As in like nagulat talaga siya. Sabi niya, SVT ba yan sir? Sabi ko, yes, that's an SVT. Sabi niya, nurse ka ba sir or doctor? Sabi ko, hindi, janitor ako. Alam ko lang ang na ang seminar. Alam ko lang ECG kasi nakikinig ako sa Tapos sabi ko, patawag na lang kay Doc. Tapos nung sinabi ko na patawag kay Doc, guys, biglang nag-arrest na talaga siya from SVT na Diyos ko, nag-proceed to VTAC, pulseless VTAC. Kaya syempre ayoko talagang tignan, no? Alam mo yung, 'di ba? Ayaw talaga natin na tignan pag family na po ang at stake, 'di ba? Family na po yung andon. Like basta traumatizing talaga siya, no? Can you imagine like tumatakbo ako palabas ng ICU tas umiiyak, tas ang taba-taba ko pa. Para akong Teletubbies na sad mood. Sige pa, so we have the atrial tachycardia. So, yes, you heard me right. The pathognomonic sign talaga guys for atrial tachycardia pag nag 170 na po no ang patient natin. If the heart rate is 170, always na yan sa sa hospital, sa ICU, sa ER, pag nag 170 na boom, SVT na to. Atrial tachycardia na to. Alam na dapat ang gagawin dapat. 'Di ba may mga protocols tayo. Later na po ang mga protocols po natin. Siguro mga 1 o'clock. Ilan ba dito ang magfe-phlebotomy? May I see the hands po sa mga magfe-phlebotomy? Meron po ba? Can you press the heart reaction? Sino ba ang magfe-phlebotomy? Parang wala. Isa lang? Isa lang magfe-phlebotomy? If isa lang i-risked natin. Kasi baka parang storytelling lang tayo later. Mr. Prades, if ever ba kung i-risked namin, in case lang na ikaw lang yung magpe-phlebotomy, okay lang ba yon?
Okay lang po.
Okay lang Baka kasi pag ikaw lang estudyante ko, baka magka-developan tayo. Meron pa. Si Miss Darilay. O, dalawa lang. Sige, depende later na sa pacing po natin. Kasi I'd like to emphasize more of the ACLS and BLS. Ayoko kasing bilisan ng ACLS po natin mamayang hapon. Okay po? Ayan. So, depende na sa natin, sa decision po ng ating may-ari na si Ma'am Joy. Okay. Sige po. So, aside from the atrial tachycardia, guys, meron kasi tayong tinatawag na vagal maneuvers. O, ito. I-emphasize ko to When we talk of vagal maneuvers, this will try to stimulate kasi the vagus nerve. And once stimulated po ang vagus nerve po natin, babagal po ang pagtibok ng puso ng isang tao. And that's good. If tachycardic ka. Pero if you're not tachycardic, if you have a normal heart rate po, tapos nag-perform ka ng vagal maneuvers, good luck. Magbe-bradycardic ka talaga. So if ever kung may massage ka mang i-offer sa ex mo, proceed na sa carotid sinus massage. Para mamatay na si ex. Charot. We have the coughing. Guys, coughing will stimulate na the patient na to have the vagus, okay, nerve to be stimulated, so babagal ang pagtibok ng puso. The squatting, the breath holding, usually kasi mag-exhale mo na yan. Exhale, and then hold breath is a form of a vagal maneuver or Valsalva maneuver kasi yan. The application of yung mga eyes po sa face natin, ayan, it will stimulate also your vagus nerve. Thus, babagal po ang pagtibok ng puso. Ito very common talaga to, the Valsalva maneuver, yung parang tatae ka, tas tubol, alam mo yung tubol, constipated, 'di ba? Ayan. So, ayun. The gagging hindi masyado ginagamit 'yan. Pero yeah. Yung iba din, digital rectal, na maipapasok po sa rectum ng client is a form of vagal maneuvers din po yan. Kaya sila tinawag na vagal maneuvers because it will stimulate the vagus nerve, and pag si vagus nerve ay stimulated, baba po ang pagtibok ng puso. Okay siya kung tachycardic ka. Pero kung normal naman po ang heart rate mo, good luck. No? Bradycardic ka later. Okay? Ayan. Now, for carotid sinus massage, I'd like to emphasize this. This should be performed for about 10 seconds. And then perform, okay, only by doctors po. MDs, okay, only. Never si nurse na mag-carotid sinus massage. Only the doctors. Ulitin ko lang ha. I've witnessed po a video sa YouTube, and hospital kasi yan eh. Na magaling yung doctor doon kasi iba naman yung style niya sa vagal maneuvers niya. Gumamit po siya ng syringe na walang needle naman. Tapos pinablow niya kay patient. Tapos sa pag-blow ni patient, guys, SBT kasi yan eh. From 185 down to 150, down to hanggang sa nag-normalize po ang kanyang heart rate. Sa point na normal na po, pinastop na ng doktor ang pag-blow niya sa syringe na walang needle. Meaning to say, ayan, nag-stimulate din po siya ng vagus nerve. Kasi it's a form of breath holding, and it's a form also na parang 'di ba? Exhale and then hold breath and bear down. Ayan, mga Valsalva maneuver po natin. Tas partly parang nag-squat din po siya sa kanyang table po. Not table, but rather hospital bed. Sa ER kasi nangyari 'yan. Ang ganda, ang ganda. Ang bilis lang ng pagkababa ng kanyang heart rate from 185. Ayan, no to normal, okay, heart rate, real quick. Amazing yan. Sige pa. So aside from that, ito na, the doctor will try to auscultate, kung nandyan ba talaga yung kanyang carotid artery. Kasi if once determined po na yan na yung carotid artery niya, then imamassage na po ng physician po natin. For 10 seconds. So 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. 6, 1,000, 7, 1,000, 8, 1,000, 9, 1,000, 10, 1,000. However, I have a question. Sir, in all ages ba dapat yan na pwedeng gawin? No. Kasi if the patient po is 50 years old, ang 50 years old kasi medyo matagal na yan sa mundong ito. So maraming na mga fat deposits yan sa kanilang neck. From thrombus, if you to massage that will become embolus. Once dislodge po sa brain ni patient, that can cause stroke. So, delikado. So, instead of massaging, pwede po nating i-instruct yung client to cough for more than 10 times. Na-experience mo na ba dati yung mag-cough ka na dire-diretso? Tapos biglang, wait lang, nahilo ata ako, friend. Kasi bumagal po ang pagtibok ng puso mo doon. Okay? Sige. Ayan. So, aside from that, let's proceed na sa ating, next topic known as the atrial flutter. When we say atrial flutter, this is the perfect sawtooth. The perfect sawtooth. Diba? Lagare, ngipin ng lagare, na if familiar kayo sa lagare, yan, the saw. Now, this is the perfect sawtooth. It's more regular compared sa mamaya na known as the atrial fibrillation. Your atrial flutter, guys, ayan, the atrial rate, changes from 250 to 350 beats per minute. Ganun siya kabilis. Kaya nga, instead of saying, P waves, I can see flutter waves. So, ano ang itsura ng flutter waves natin? So, para po siyang, saw. The sawtooth appearance po. The sawtooth waves, or the flutter waves ang tawag natin. Next to flutter waves or atrial flutter will be the atrial fibrillation. Guys, atrial fibrillation, ayan, you can go as high as or as fast as 400 to 600 beats per minute. Grabe, no? Grabe ka dysrhythmic. And we call this one as the irregular. Pag sinabi po nating irregular, like, di ba, from 400 to 600 beats per minute. And are you aware that the complication na which is really common to your atrial fibrillation will be the complication known as the stroke. Ang dami pong nagkaka-stroke. Kaya careful tayo. Kaya nga 'di ba pag may atrial fibrillation, you watch out for the occurrence of stroke. Kaya usually na may mga protocols na po sila for stroke prevention. Kasi grabe na ang ang dysrhythmia. Okay? Sir? Paano ba mag-identify ng stroke ngayon? So we do have the warning signs of stroke. Dati kasi fast lang. 'Di ba? To identify stroke, we have the mnemonic fast. However, in-update nila ngayon, it should be B fast. Bakit B fast? Letter B, E. BBB stands for the balance. If there will be no balance at all, biglang natumba ang client, that can be a warning sign of stroke. Next, we have the I. If there will be no vision. Ayan. If no vision, guys, warning signs of stroke po yan. Ano yung FAST natin, sir? F. Letter A. Letter S. And then we have letter T. Guys, your letter F, stands for facial drooping. So we have the facial, ayan, drooping natin. Biglang nagsag na ang one portion ng face po. Next, we have the arm drifting. Pag sinabi po nating arm drifting, biglang nawala ng strength ang isang arm mo, biglang bumaba. Kasi you're going to instruct the client, ma'am, na ayan, parang hands forward tayo, ma'am. Tapos biglang nawala ng strength ang isa, ang tawag doon arm drifting. Biglang nag-sway na bigla. Next, we have the letter S, the slurred speech. Pag sinabi nating slurred speech, pag sa states kasi, na ma'am, repeat after me, you can teach old dogs new tricks. Sabi ng patient mo, you can teach old dogs new tricks. Okay, walang stroke yan. Pero pag sinabi niya, you can teach old dogs new tricks. Ayan. Meaning may stroke po si patient. Okay? Pero pag sinabi ng patient mo, you can teach old dogs new tricks. Na bayot si patient, maarte. Ayan. Alam niyo ba sa Philippine setting po, ang dami kasi na pagkakamalang stroke. No? Ganito. Ito, syempre na experience sa 911 eh. Ganito ang nangyari. Oh. Ma'am, repeat after me. The sky is blue. Sabi ng patient, the sky is blue. Diyos ko, iba po ang ngongo sa na-stroke, guys, ha. Malalaman mo naman kasi pag ngongo talaga. Kaya ang dami pong may mga cleft lip or cleft palate na pagkakamalang na-stroke. Okay? So, i-identify mo kung may speech problem ba talaga siya, which occurred na even before pa, and of course, I'm referring to cleft lip and cleft palate. Malalaman mo naman talaga kung may, pag ganito, guys, ayan, tas, di ba yung face niya, na may facial drooping tayo, tapos may difficulty na in talking kasi may slurred speech na po siya, okay, may stroke po yan. So, further test, ay kailangan po. So, lastly, letter T, guys, it's the time to call 911. Your letter T is time to call 911. So, what's the emergency number? Malamang it's 911 also. Okay? Ayan. Sige po. So, again, to determine kung may stroke ba talaga si patient, so we need to have the mnemonic be fast. Dapat be quick daw. Be fast. Check for the balance. Check for the eyes. Na kung walang balance, kung wala na pong vision, then check. Warning signs of stroke. May facial drooping, may arm drifting, may slurred speech tayo. That's the time to call 911. Okay? Pero if ever po, kung let's say nasa ward ka, huwag ka naman mag-activate ng code blue. Hindi naman po nag-arrest ang client natin. May warning sign siya of stroke. Kaya you call the attention of the attending physician ng client natin. Meron akong kasamahan dati. Diyos ko, may warning signs lang ng stroke. Nag-code blue agad. Ayo, napagalitan kami lahat. Bakit? Nag-activate ng code blue. Okay lang sana kung nag-arrest. May warning signs lang siya ng stroke. So, pwede nang i-inform lamang ang physician, do not activate the code. Because activation of the code, malamang if that's, if pulseless si client mo, for the code blue ha, if pulseless, diba? No breathing, no? Ayan, so we need to start high quality chest compression there. Okay? Ayan, for a while, i-ano ko lang, i-change ko lang tong si AFib natin, gawin ko 290. And then for the AFib, 372. Para mas accurate pa. Pakita ko muna sa atrial tachycardia. Okay, this is an example of an atrial tachycardia or the supraventricular tachycardia. Guys, anong sabi ko? Pag ang heart rate niya po is 170, diba? That's the pathognomonic sign for SVT. So the heart rate here is 176. The rhythm is regular, the same distance. However, the P waves are not clear. They are buried preceding to T wave. And the QRS is narrowed in nature. So therefore, the patient here is suffering from atrial tachycardia or the supraventricular tachycardia. Now, tignan mo ang next natin. Okay, tell me the heart rate. The heart rate is 290. The rhythm is irregular. I can see flutter waves. Ang tawag dyan, flutter waves po. No P waves, but rather flutter waves. Now, followed by QRS, which is, narrowed in nature. So therefore, the patient here is suffering from atrial fibrillation. Next, this is irregularly irregular. Mapapansin naman eh. Tignan mo ang mas more regular. The heart rate is 372. The rhythm is, it's more regular. But then again, this is irregular. More regular lang siya if you're going to compare that one sa isa na kanyang kalaban, which is kanina, that's the atrial fibrillation. So this is the perfect sawtooth. Diba? Perfect lagare. So this is atrial, atrial flutter or the atrial flare. Ako dati tinatandaan ko lang parang pag M, parang M siya, no? M, parang McDonald's. Ano bang meron sa McDonald's? McFlare. So atrial flare. Kung i-compare mo naman kanina na masyadong magulo, atrial fibrillation naman yon. No? And very common po yung stroke po doon. Okay po? Now, let's advance na sa ating mga ventricular problems, guys. Okay, let's have ventricular problems. You can eat po there, ha? Walang problema. Pwede kayong kumain. Pwede kayong magkape. Pwede kayong mag-juice. Pwede kayong mag-coke. Pwede kayong mag-snacks. Walang problema. I'm sharing to you our virtual snacks. Mag-virtual snacks po tayo, guys. Ayan. Okay, let's have the first ventricular problem known as the monomorphic ventricular tachycardia. In monomorphic ventricular tachycardia, malamang VTAC kasi ito eh. So, mag-start tayo ng 150 and above. As is natin to kasi hindi naman pala siya atrial. So, ventricular problem, pwede kasi siyang may pulso, pwede po siyang walang pulso. We will greatly and solely rely po at tignan talaga na ang kanyang QRS if that's widened. So the heart rate here, it doesn't matter as long as na the QRS, if that's widened, that's ventricular problem. Okay? Pag wala pong P wave na nakikita, if that's purely QRS, then ang tawag natin ventricular problem. Now, everybody say monomorphic.
Monomorphic.
Thank you, Doc. Pag sinabi po nating monomorphic, meaning to say, 'di ba? Solo, isang itsura lang siya. Kasi pag polymorphic po, in multiform. Kaya as you can see sa ating strip po sa baba, 'di ba? Isang thumb, isang itsura lang siya. Widen. The same ang itsura, kaya it's monomorphic. Now with monomorphic ventricular tachycardia with a heart rate of 101 to 200 beats per minute, and usually, and malamang wala talaga siyang P wave, guys, na Now, P waves are usually not seen. Now, it's absent. And it's purely QRS. If that's purely QRS and isang itsura, ang tawag doon, monomorphic ventricular tachycardia. However, kasi, pag marami na po siyang itsura, ang tawag doon, it's polymorphic. Okay, for the polymorphic guys, mas worse siya eh. Mas grabe ang dysrhythmia ng patient natin dito. Kasi kung kanina in one form siya, ito in multi-form na po siya, kaya it's polymorphic. Iba-iba ang itsura. 'Di ba may thumb na parang basta widen lang kanyang QRS, may thumb, tapos biglang basta widen lang kanyang QRS. So, it's in multi-form. Pero mas delikado po ang multi-form. Now, sa screen niyo po, this is an example of a twisted one. Now, this is a French term known as the torsa de pois or the torsades de pointes or the torsa de pois. And alam niyo ba ano ang cause kung bakit may torsa de pois ang patient? Ayan, this is brought about by hypomagnesemia. Magnesemia. So pag sinabi po natin, okay, magnesemia, bumaba po ang magnesium sa kanyang katawan. So ang tawag natin doon, hypomagnesemia, expected na lumalabas po na parang tinwist po yung ECG po natin, and that's your torsa de pois. No? Or kung ayaw mo, the torsades de pointes, basta I know for a fact na this is a French term, which is your torsa de pois. Okay? Ayan. So we have another examples po ng ating mga polymorphic ventricular tachycardia. So yes, na ito kasi hindi na po sila mga basic na ECG, but they are advanced na ECG na po sila. Pero ang pinaka-common talaga dito, brought about by hypomagnesemia, will be the torsa de pois. Tinwist kasi siya eh. Na twisted point. From the word itself, twisted, torsa de pointes, or the torsa de pois. Now, pag bibigyan mo ng magnesium si patient, magnesium sulfate, marirelieve talaga ang polymorphic ventricular tachycardia po natin. Okay? Ayan. So, let's proceed na po to another form na po ng ECG po natin. I-disregard niyo lang yung cardiac arrest kasi if that is, 'di ba, pulseless na VTAC, malamang cardiac arrest din po 'yon. Pero hindi sa lahat ng oras na pag VTAC ay cardiac arrest na, no. Kasi meron pong VTAC na may pulso. Meron din isa na VTAC na walang pulso. Yun yung cardiac arrest. Now, next, let's proceed na po sa ating another problem, which is your ventricular fibrillation. Guys, ito parang worm to eh. You cannot say na that's irregular, but rather it should be what? Called as chaotic. Na? So the heart rate here is indeterminate, so wala talaga siyang heart rate. The heart rate is 0. However, the rhythm ay chaotic. Masyadong magulo. Na parang naging worm tuloy ang ECG po natin. Parang mga worms, no? Maliliit na mga worms. Pwedeng malaki, pwedeng maliit din kasi. Meron kasi tayong coarse, meron din tayong fine, okay, ventricular fibrillation. There's no P wave, there's no PR interval, there's no Qrs complex. And are you aware that your ventricular fibrillation means a sudden cardiac death? A sudden cardiac death experience known as the VFib. Kaya pag narinig po natin VFib, that means sudden cardiac death experience. Ayan na sila. So we have the coarse, meaning bigger ones. We have the bigger ones, big. Tapos itong, fine will be the smaller ones. Kaya nga mamaya sa ECG, let's say pag pag nag-assistole si client, you need to maximize ECG. Why? Akala mo straight line lang para masabi mong assistole. Yun pala, pag zoom mo, wait lang. Fine pala to ventricular fibrillation. Ay, kaya pala, sir. Kaya pala, no? Kanina pa tayo, akala kasi natin assistole, so we did not, 'di ba? Let's say defibrillate the client. Hindi natin siya defibrillate kasi akala natin assistole. Yun pala, kung nag-zoom lang tayo at nakita po natin na hindi pala siya assistole but rather fine ventricular fibrillation, then sana ma-revive natin si client, no? By of course, no? di ba, changing the protocol to a shockable rhythm. Kanina akala mo non-shockable. Hindi ka kasi nag-zoom. Pero kung nag-zoom ka sana, shockable pala siya, na edi sana na okay si client at buhay si client. Okay po? Ayan. Next, we have the asystole. Guys, di ba, flatline ang tawag natin dito pag nasa ER. Pero pag nasa OR, ang tawag natin cardiac standstill. Your asystole po, or others call this one as the asystole. Na? So we have the heart rate here. The heart rate na is 0. Wala talaga siyang heart rate. Pwede rin kasi may P-wave asystole, mama. Ipapakita po natin si P-wave asystole. The rhythm here is no rhythm po, no P-wave, no QRS. As in like wala. Flatline lang po siya. And sometimes pwede rin po siyang P-wave asystole. May P, may P, may P, may P. The same lang po. It's our P-wave asystole or cardiac standstill, di ba, or flatline. However, kasi meron tayong flatline protocol or asystole protocols. What are they? Number 1, you check for the heart rate. You check for the heart rate. Ayan, or pulse rate rather. No? Heart rate or pulse rate. Pulse rate na lang ilagay natin. You check for the pulse rate. Ayan, you check po nasa kanyang carotid pulse natin. So 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. There is no pulse. Check. Next, you check for Ecg leads. Let's say si Doc, sabihan niya si nurse, nurse, please check for the Ecg leads. Ayan, sasabihin ni nurse, all Ecg leads are in place po, Doc. Okay? Then we need to maximize Ecg 5 to 10 times. Pag maximize mo ng Ecg 5 to 10 times, asystole confirmed. Doc, asystole talaga siya. Kasi nung nag-maximize ka, sige, 1, 2, 3, 4, 5, okay, flatline talaga. Pero habang nagma-maximize ka, ano to? Fine ventricular fibrillation. So you change the protocol. From a From a non-shockable to a shockable one, dapat magpapashock dapat si Doc kasi hindi pala siya asystole. But rather, a fine ventricular fibrillation po. Nakuha po ba? And so we are done na po sa ating asystole protocol sa wag po bilisan na let's say i-pronounce agad na, oy, asystole to. No. You proceed with protocols muna before po natin nasabihin na asystole talaga. Ayan. So we have the asystole and then we have the P-wave. Kasi may P-wave siya eh. Pero asystole pa rin siya. So it's your P-wave asystole. Asystole, the same lamang po. Next, we have here the PA or the pulseless electrical activity. Guys, when we say pulseless electrical activity known as the PA or the PA, situation kasi yan. From sinus bradycardia to nag-Vfib si patient, to nag-asystole si patient. Tapos akala mo may PQRST na, uy, na-revive na si client. Tapos sasabihin ni Doc, okay, nurse, please check for the heart rate or for the pulse rate of the patient. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. Doc, bakit walang pulso? Yes. Kasi on arrest pa rin si patient natin. Ang tawag doon, it's pulseless electrical activity. Meaning the same pa rin sila sa tinatawag na asystole po natin. Meaning on an arrest setting pa rin si patient. Now, what are the reversible causes ng PEA po natin? So we have the reversible causes. Guys, everybody say reversible.
Reversible.
Thank you so much, Doc. Ayan, we have the reversible causes. We have the H's and T's. Pag sinabi nating reversible, if we're going to identify that, let's say, tatanong na si Doc, sasabihin niya, okay, what are the possible reversible causes kung bakit kaya nagka-PA ang client natin? Tapos sasagot si nurse, Doc, kasi kanina po, Doc, when the patient came in sa ER po, may mga signs of dehydration kasi siya. Okay, pasok sa banga, hypovolemia. Ayan, Doc, nanlalamig din ng client kasi upon checking the temperature, okay, pasok sa banga, hypothermia. Hypothermia and hypovolemia, guys, these are really common causes common reversible causes. If you're going to treat them, then wala talagang PA later. Next, we have, okay, letter H, we have the hydrogen ions. We have hydrogen ions. Aside from hydrogen ions, we have the hypokalemia, and then we have the hyperkalemia also. So may mga imbalances po tayo na pwedeng sobra, pwedeng kulang, especially sa potassium level po. So we have the hypovolemia, hypothermia, hydrogen ions, okay, hypokalemia, and then we have the kalemia. Okay po, so we have the H's po natin. Next, for the T's naman po natin, guys. Letter T stands for tension pneumothorax. Tension pneumothorax. Aside from tension pneumothorax po, another letter T will be the tamponade. The cardiac tamponade po natin. Aside from tension pneumothorax, aside from tamponade, we have the toxins, lalo na pag may mga drug overdosage po ang client natin. Next, letter T for thrombosis. Diba? Your thrombosis po, whether if it's a pulmonary thrombosis, ayan, or a coronary. Pag pulmonary sa lungs po, pag coronary sa heart po, no, yung thrombosis. So again, these are the possible reversible causes, ayan, ng PA po natin. If na-treat mo po yan, then wala pong mangyayari, okay, PA later, or the pulseless electrical activity. So we have the H's, the hypovolemia, hypothermia, hydrogen ions, and then we have the hypokalemia, hyperkalemia. Next, we have the T's po natin. We have the tension pneumothorax, we have the cardiac tamponade, we have the toxins, we have the thrombosis, whether if it's pulmonary, and your coronary thrombosis. Okay? Now, after this, I'll be showing you a video. A recap muna tayo na sa ating cardiopulmonary resuscitation via a video po for a while. For a while lang po ah.
Once you start CPR, you want to really make it count because patients are much more likely to survive if you perform high-quality CPR than if you perform poor-quality CPR. And there are 5 major determinants of CPR quality, which we're going to discuss in some detail. The first is the rate of compressions. 100 to 120 is the rate that every rescuer should be aiming for. 2 is adequate compression depth. We want to go about 2 to 2.5 inches or 4 to 5 centimeters. 3 is continuity. You should be performing CPR for a minimum of 60% of your total resuscitation time, if not more. 4th is chest wall recoil. That's diastole in cardiac arrest, and that's what allows the heart to refill. So we want to make sure that we allow the chest to recoil so the heart can fill normally, making each compression count. And last is hyperventilation. Hyperinflating the lungs decreases cardiac output and is another variable that produces adverse outcomes in cardiac arrest. So let's start with compression rate. There have been a number of studies looking at rate, and this is one example. In this study, they looked at the mean rate of chest compressions among a large sample of cardiac arrest patients, and they found that the patients who had compressions at a rate of roughly 100 to 120 had the highest probability of ROSCE, which stands for return of spontaneous circulation, and they also had the highest probability of survival to hospital discharge or having a longer-term positive outcome. So 100 to 120 is the rate you want to go for, and there's actual science showing us that patients are more likely to survive when we use that rate. Compression depth. We have a similar study looking at depth as an isolated variable. Again, for patients getting return of spontaneous circulation back, the optimal compression depth was just under 5 centimeters. And same thing for survival to hospital discharge. The optimal compression depth was just a little bit over 5 centimeters. And what they found in general is that any compression depth over about 4 centimeters or 38 millimeters produced an odds ratio of 1.91 of survival to hospital discharge, meaning that if you have compressions of greater than 38 millimeters across the board, you're twice as likely to survive. So it's a really important variable and a really easy one to optimize. This graph is about chest compression fraction. So in this study, they looked at the percentage of time in the overall cardiac arrest that the patient had active chest compressions being performed. And they stratified according to the percentage. So 0 to 20, 20 to 40, 40 to 60, et cetera. And they found, not surprisingly, a linear increase in the likelihood of return of spontaneous circulation as the chest compression fraction increased. So if you spend more time during the code performing CPR, you're going to get a better outcome and a higher probability of survival. This is the same data, but this is actually a survival curve rather than the group stratified data. And once again, chest compression fraction of 0.8, 0.9, or 80 to 90% of the time produce the highest likelihood of return of spontaneous circulation. In another study looking at chest compression fraction, the outcomes were a little bit different. In this study, they found that actually a 60 to 80% chest compression fraction produced the highest odds ratio of survival to hospital discharge, and that's what the current guideline recommends. So you want to be at a minimum of 60%, ideally closer to the 80% range for your chest compression fraction. The bottom line, though, is you're clearly never going to know numerically what your fraction is during the course of a resuscitation. You just want to make sure that your CPR is as continuous and uninterrupted as you can possibly make it. So chest wall recoil is a physiologically important variable, but there's actually no human studies on it that demonstrate improved survival because it's kind of a difficult phenomenon to study. But basically, the idea is if you lean on the chest in between compressions, you're going to increase pressure, right? You're smashing down on the raise the interthoracic pressure. Well, we all know that positive pressure ventilation also raises the interthoracic pressure. So if you cram more air into the lungs, you're going to raise the thoracic pressure. And the bottom line, what brings blood back into the heart during diastole? It's negative interthoracic pressure, right? It's that negative pressure gradient that pulls blood from the periphery back up to the heart. So if you raise the interthoracic pressure and make it not negative, you're going to prevent the heart from filling, and you're going to decrease your cardiac output by decreasing your stroke volume. The ultimate effect, again, is going to be impaired cardiac output, and that means less blood flow to the heart itself, less blood flow to the brain, and less likelihood of spontaneous circulation. So, bottom line, high quality CPR is what you need to do to optimize your chances of survival. And the determinants, once again, are push hard, 4 to 5 centimeters, push fast, 100 to 120 compressions per minute, keep it going. You want to make sure your chest compression fraction is a minimum of 60%, if not more, during the course of the arrest. And avoid hyperventilation and chest wall leaning. If you do those 5 things, you're going to increase your patient's odds of survival. So, once you have really good quality CPR going, what's the next question you need to answer? You've already decided your patient is pulseless. You've already initiated compressions. What do you need to know now? The answer is, of course, what is the cardiac rhythm? And specifically, is it a rhythm that we can treat with electricity? Is it a shockable rhythm? So, shockable rhythms, like we said before, are more likely to survive. Patients who can be shocked are more likely to live through a cardiac arrest. But defibrillation is a very time-sensitive intervention, meaning the faster you do it, the more likely it is that your patient's going to benefit from it. So for shockable rhythms, we consider defibrillation to be more important than anything else you can do, more important than CPR, more important than ventilation, more important than drugs or IV access. It is the single most important thing that you can do. So if you have a shockable rhythm, you need to know early and you need to treat it early. Here's one of our shockable rhythms. This is ventricular fibrillation. It's very easy to identify. It's randomly fluctuating. It goes up and down. There's no pattern. There's no rhyme and reason. There's no QRS complexes. It's just a disorganized squiggle. The second one is ventricular tachycardia. Now, in VTach, there actually is organization to the QRS complexes, but they're wide and bizarre looking. So anytime you have a fast rhythm with wide QRX complexes, you should suspect that to be ventricular tachycardia. And by the way, these are the two rhythms that the automated defibrillators that you see in public places are looking for when they determine whether or not a patient should be shocked in cardiac arrest. So why do we only shock VFib and VTach? This frustrates a lot of students because you see on TV, everybody in cardiac arrest gets shocked and they all jump up and come right back to life, right? Well, it doesn't work that way in the real world because the whole goal of using electricity is to reorganize a rhythm that is disorganized. Now, when you are in a non-shockable rhythm like PEA, you have some major problems on the table, but electrical disorganization is not one of them. It's not an issue for patients in non-shockable rhythms. And at best, if you go and shock a non-shockable rhythm, nothing will happen. At worst, you could potentially hit the patient at the wrong point in the cardiac cycle, cause an R on T phenomenon, and ultimately precipitate a dysrhythmia like ventricular fibrillation. So the last thing you want to do in a cardiac arrest is take somebody who has a normal rhythm and turn it into VFib. That's clearly not benefiting anybody. So we don't perform defibrillation for any rhythm except our two shockable rhythms, VFib and VTach. I mentioned before that defibrillation is a time-sensitive intervention, and this graph clearly shows why. So as you can see, the more time that elapses as we move along the axis there, the lower the likelihood of survival for the patient. So for patients in shockable rhythms who are getting shocked within the first minute, you can see 35–40% of those patients are surviving. But by the time we get out to 6 minutes, it's less than 20% of the patients surviving. So we really want to make sure that as soon as we're humanly able to do so, we assess the rhythm and we defibrillate if we identify a shockable rhythm. Again, short time to defibrillation, high likelihood of survival. And as we go down to 2, 3, 4, 5, 6, and more than 6 minutes, you can see that the odds ratio, or the likelihood that the patient is going to survive the event, goes down consistently with every minute that passes. It's really key to do this quickly. All right. Now, once you've gotten your high-quality CPR going and you've assessed your rhythm and defibrillated if it's indicated, what do you want to do next? Well, this is when you can start thinking about respiratory support for your patient. So you can initiate bag valve ventilation in order to give your patient some oxygenation. You want to also coordinate your chest compressions with your breathing. So you're going to do 30 compressions followed by 2 breaths, 30 compressions followed by 2 breaths. You also, if you're in a hospital setting, are going to establish vascular access, and you're going to continue reassessing the rhythm every 5 cycles or 2 minutes for the duration of the resuscitation. Now, a lot of students ask me, Dr. Young, this is all great, but this is like basic stuff, right? What about the cool stuff like putting in airways and pushing drugs? Well, unfortunately, advanced interventions in cardiac arrest don't really make much of a difference. This is a study that came out of Scandinavia that really showed whether you're performing basic life support or advanced life support, your outcomes are very similar. So in these 2 cases, you can see the red line represents patients who got no IV access, no IV drugs, and no advanced airway interventions. And the green line represents patients that did receive those interventions. And you can see how very similar the outcomes for both groups were. So bottom line is that CPR and defibrillation is by far the most important element of your resuscitation. And all the advanced stuff really doesn't make as much of a difference as we'd like. So let's get back to our case. So we have our 58-year-old guy who collapsed at a sporting event. What are we going to do for him? Well, like we already said, 1, we're going to call for help as quickly as we can. 2, we're going to think CAB, so we're going to go to him and we're going to decide whether or not he's got a carotid pulse. If he doesn't, we're going to go ahead and initiate chest compressions. And then once we can get access to a defibrillator, which hopefully at a sporting event would be pretty quickly, we're going to put it on, assess the rhythm, and defibrillate if, of course, it's indicated.
Okay, sige po. So let's divide na po our scenarios into 3 scenarios. So we have the pre-arrest, and then we have the arrest setting, and then we have the post arrest setting po. So pag sinabi po natin pre-arrest, arrest, then we have the post-arrest setting. Are you aware, guys, na pag pre-arrest setting po, we are performing the ACLS here, lalo na if the patient is conscious. So if the patient is conscious, okay, we need to perform the ACLS protocol. Pero pag arrest na po ang patient po natin, nag-arrest na siya, ang tawag natin BLS protocol na po. Lalo na pag unconscious client natin. Okay, so we have the pre-arrest, we have the arrest, and then we have the post-arrest setting. So ano bang ito-talk natin or discuss natin with the pre-arrest setting? So the most common, ECG readings here will be, number 1, we have the Sinus Bradycardia. Next to Sinus Bradycardia, we have the SVT or the Supraventricular Tachycardia. And then we have the VTAC na, tapos it's monomorphic. Meaning to say it's with pulse. Na? So VTAC with pulse po tayo. So ito muna yung i-discuss natin na itong tatlong to. Sinus Bradycardia management, SVT management, then we have the VTAC with pulse management as part ng pre-arrest po natin. Let's discuss sinus bradycardia. Now, with sinus, bradycardia, sir, AHA recommends, or American Heart Association recommends, that we need to check the BP first to know whether if it's stable or unstable BP. So if the BP, guys, is greater than 90/60, ang tawag natin doon stable. Ang tawag natin stable sinus bradycardia. But if the patient's BP po is less than 90/60, ang tawag natin doon unstable. So we have the unstable. Sinus bradycardia. Guys, everybody say stable.
Stable.
Thank you so much, ma'am. Pag sinabi po natin stable, all you need to do is that you need to observe the client. Just observe niya. Do not treat the client kasi stable naman si client eh. Stable, sinus bradycardia. Just observe the patient mga kasi pababa ng pababa lalo. Or baka magka-dysrhythmia ang patient natin. So you need to what, no? Pwede nating tawagan agad si doktor po natin. So again, pag sinus bradycardia greater than 90/60, stable naman siya, just observe the client po. However, if unstable na po yan, we have a mnemonic for this one. Ang mnemonic ko po will be at de. Bakit siya at de, sir? All trained dogs are excellent. Known as your the at de. Letter A, it's your the atropine sulfate. Now with atropine sulfate kasi, diba? This is the drug of choice. The first drug of choice na in treating sinus bradycardia. Meaning the goal of therapy here is to increase the heart rate of the patient kasi bradycardic kasi siya. So pabilisin po, pataasin, and that's your atropine sulfate. Now we have the 0.5 milligram times 6 doses with a maximum dose of 3 milligrams po. And given, and this is usually given every 3 to 5 minutes po. Okay? So again, we have the first drug, known as the atropine sulfate at 0.5 milligram times 6 doses with a maximum dose of 3 milligrams given every 3 to 5 minutes. However, I have a question, sir. What if hindi po effective ang atropine sulfate natin? We have another management known as your letter T. Ang tawag natin doon, it's the transcutaneous pacing po natin. So we have transcutaneous pacing. So we're going to pace the client. May video po tayo later sa pacing po. Next, we have our letter D. We have dopamine. Pampabilis, 'di ba? Ayan, it could either be pampabilis ng heart rate or pampataas ng BP, ang dopamine kasi natin, or pwedeng pampaihi din ang BP na, ang dopamine rather. Kasi ang dopamine, guys, meron tayong 3 doses na pwedeng ibigay. We have the renal dose, kung gusto mong paihiin, kasi 'di ba a good cardiac output must have a good renal output. Kasi magulat ka, wait lang, bakit scanty lang po ang urine ng patient natin? Baka kasi may mga congestions na nangyayari sa loob. Kasi kung ano yung pinainom mo, dapat lalabas din po. Kaya a good cardiac output must have a good renal output, or else may mga congestion na nangyayari. Aside from renal, we have your, the vasopressor dose. Cardiac na lang muna. Isulat muna natin si cardiac. Aside from cardiac, ito na yon, the vasopressor. Kasi pataas ng pataas yung dosage natin eh. For the renal dose, guys, kung gusto mong paihiin, pero sa case na to, wag mong paihiin. Baba na nga ang BP, tapos pinaihi mo pa. Ayan, so it's 2 microgram per kilogram per minute. That's for the renal dose. Dito tayo mag-focus, guys. Cardiac. Ba't mo diniscuss si renal? Wala lang. Gusto ko lang para at least hindi nyo makalimutan. Pag cardiac po, it's 5 microgram per kilogram per minute. Memorize lang natin. Kung BP naman ang focus mo, let's say, di ba, yung the return of spontaneous circulation later, yung tipong kaka-revive lang natin sa client, pero mababa pa rin ang BP ng client, edi bigyan mo ng vasopressor dose niya, which is a 10 microgram per kilogram per minute. Ito pala yung mga sir, naririnig po natin. Pagbaba ang BP ng patient, you give the vasopressor dose of 10 microgram per kilogram per minute. Do I need to check the or to weigh the patient? Exactly. Na kasi may per kilogram tayo per minute po. Now, aside from the dopamine, letter E will be the epinephrine. So we have, okay, the epinephrine. We have the first dose ng epinephrine po natin. Ayan, we have the first dose or the initial dose. Ayan, we have the initial dose. And then we have the maximum dose. The initial dose, guys, will be, ano kayang initial dose natin? Anyone from the group? Initial microgram. Ayan, it's 2 microgram per minute. Sir, what's the maximum dose? 10 microgram per minute. So we have 2 as the initial dose, 2 micrograms per minute. And the maximum dose will be 10 micrograms per minute. So again, our mnemonic for Sinus Bradycardia, guys, which is unstable, is the mnemonic at D. Atropine first. If atropine is ineffective, then proceed with transcutaneous spacing. If transcutaneous spacing is ineffective, proceed with dopamine. If dopamine is ineffective, then you proceed with the last resort po, and that's the epinephrine. Initial dose of 2 microgram per minute. Maximum of 10 micrograms per minute. Okay na po ba? Okay, let's have another problem. Ayan, aside from your sinus bradycardia, let's discuss SVT or the supraventricular tachycardia. Now with supraventricular tachycardia, guys, or atrial, this is your atrial, ayan, tachycardia. And malamang part pa rin to ng pre-arrest setting po natin. With SVT kasi, guys, or atrial tachycardia, we always check the BP. Ayan, to know whether if it's stable or unstable. O ayan, greater than 90/60, it's stable. So ang tawag natin, stable SVT. Ano ba ang management natin? Usually 2Ps po. Your first letter P will be the physiologic management. Your physiologic management po will be your carotid, yung kanina na-discuss natin, sinus massage. Your carotid sinus massage for about 10 seconds, you can actually perform that one if you're a doctor. Pero if you're a nurse, you're not allowed to perform the carotid sinus massage. Pero if ever naman po, kung greater than 50 years old ang patient natin, just encourage the patient to cough. So there should be coughing for 10 times or more. Pwede pa ipa-cough ang client natin 10 times, or ayan, more po. And that's for the physiologic, Physiologic therapy, carotid sinus massage for about 10 seconds. But if the patient is 50 years old, guys, now encourage the patient to cough. Next, we have another letter P will be the pharmacologic. It's the pharmaco. Pag pharmaco, more of drugs po tayo dito. Now, SVT, ayan, you can give your adenosine. Okay, so we have the adenosine. Ayan. If that's the adenosine po, ayan. Alam niyo ba ang adenosine po natin? Dapat mabilisan to. So there should be a rapid IV push. Sir, bakit kailangan may rapid IV push? Because the half-life ng ating adenosine is only for about 10 seconds. Sorry. If that's for 10 seconds po, alam niyo ba pag lumagpas na po tayo ng 10 seconds, meaning to say, 50% na lang ang gagana, kaya tawag doon half-life. So pag sinabi kong half-life of 10 seconds po, pag let's say, ayan, no, naabutan mo talaga ang 10 seconds. So 50% na lang ang gagana. And then what if naman, sir, let's say 20 seconds. E de, ano ang half ng 50%? E de 25% na lang po ang gagana sa drug na yan. To maintain its drug, no, ayan, the drug, okay, effectivity po, kailangan maibigay talaga siya na in less than 10 seconds. So usually, ina-IV push po yan for about 1 to 3 seconds. Ganun kabilis. After pag-push po ng 1 to 3 seconds, binibigyan pa talaga ng 2+. Okay, you flush it with 20 cc of plain NSS. Just to make sure na papasok talaga siya sa systemic circulation. Ulitin ko ha. Via rapid IV push. Because the half-life is only 10 seconds. So meaning, 2 to 3 seconds po or 1 to 3 seconds, i-push dapat siya ng mabilisan. Or else, pag lumagpas ka ng 10 seconds, 50% na lang ang effectivity ng drug. Pag 20 seconds, edi half ng 50, edi 25% na lang po. See? Sayang lang din. And are you aware, sa first dose pa lang ng adenosine po, bumabagal na talaga ang pagtibok ng puso. And that's okay because this is SVT, di ba? Nagwa 170 po ang client natin dito. So sir, matanong ko lang, what's the dose? We have the first dose, the second dose, and then we have the third dose. For the first dose po natin, guys, kaya nga adenosine, adeno 6, 12, and then 12. Ayan. And then this should be given every 1 to 2 minutes po. Given. Ayan. Q. Okay, 1 to 2 minutes po. Every 1 to 2 minutes, dapat magbigay po. First dose, 6 milligrams. Usually, sa first dose pa lang, via rapid IV push, tapos you flush it with 20 cc of plain NSS, that 175 na will slow down. No? Ayan, achieving a normal heart rate po kay patient. Pero pag hindi pa rin, then you can give the second dose. Pag ayaw pa rin, you can give the third dose. Pero imposible na po yan kasi sa first dose pa lang, nagtitake effect na po na si adenosine po natin. Okay, that's for the SVT if stable ang BP. What if unstable? Guys, ilagay mo less than 90/60, unstable. Sir, what if we are having an unstable SVT? Now, kung kanina 2Ps, ngayon 2Ss. Bakit 2Ss, sir? The first S, you need to sedate the client. Lalo na pag pangit, isedate po. Pero pag gwapo, iseduce. Charot. So, you need to sedate the patient, guys. Ano bang ginagamit natin pang sedate? Letter D. Diazepam or diatabs? Pag tumatay ka, malamang diatabs. Malamang masarap yon, di ba? Matulog kasi kakatain mo lang ng sobra-sobra. Pero dapat pang sedate po is the diazepam. Ayan. Pag walang diazepam, we have the midazolam. Pag walang midazolam po, we have the propofol. Next to propofol, we have etomidate. So we have diazepam, we have midazolam, we have propofol, we have etomidate. Mamili ka lang po na pang sedate ha. Huwag mo pong ibigay lahat yan or else sedated po ang patient natin for life. If you're familiar kay propofol, ito po yung kinaadikan ni Michael Jackson. 'Di ba? With propofol kasi nung inotopsy po si Michael Jackson, grabe po yung nakita sa kanya na propofol. Ayan. Sige po. So, aside from the diazepam, midazolam, pwedeng mag-propofol, pwedeng mag-etomidate. Sa Philippine setting, hindi masyado common si etomidate. Pero sa Philippine setting, yes, common po si propofol, lalo na if you want to intubate the client. Tapos gusto po natin na unconscious or let's say, 'di ba? Yung sedation po dapat, under sedation na intubation. Okay? Ayan. So, aside from sedating the client, you can now perform the synchronized, it's letter S, the synchronized cardioversion. Guys, if the question is referring to SVT, sounds like 50 joules. Pero pag VTAC naman po, na let's say unstable, it's at 100 joules. Tandaan mo na lang ha, SVT sounds like 50. Pero pag VTAC naman po, 100 joules naman yan. Guys, synchronized cardioversion, from the word itself synchronize, you're going to sync with your client kasi kailangan mo siyang isedate before mo siya kukuryentehin. Kasi pag ikaw daw, na-conscious ka, tapos kukuryentehin kita, hindi ka kaya ma-offend. So malamang ma-IR ka later. So patutulugin mo muna si client before mo siya kukuryentehin. Meron kasi din tinatawag na unsynchronized cardioversion. Yun yung the usual na nakikita sa ER. Kasi the patient na presented, syempre unconscious kasi ang client mo, so no need to sedate the client. Bubuhayin natin siya at iwat, nakukuryentehin po natin siya. That's unsynchronized. Pero since ikaw na conscious, kukuryentehin kita, kailangan mo na napatulugin si client. So ang tawag doon, synchronized cardioversion. Kaya pag synchronized, the first letter will be letter S. You need to sedate the patient first. Sedate by using diazepam, midazolam, propofol, and then we have etomidate. Next po guys, next topic will be the VTAC or the ventricular tachycardia, but this time this is with pulse. So ang tawag doon, VTAC with pulse. Usually mga monomorphic din to eh. Now, if VTAC naman po, with pulse naman si client natin, you check the patient's BP. If the patient's BP is greater than, 90/60, then this is stable. Guys, pag stable po yan, 2Ps na naman po tayo. Ulitin ko ha, 2Ps. Letter B, physician. Sir, bakit physician? You need to seek consultation. So meaning, i-inform natin si doc. Hello, doc. Ayan. So we have, seek consultation. So in seeking consultation, tawagan po natin si doctor. Doc, we have a patient here suffering from ventricular tachycardia but with pulse naman po, doc. At least na-inform po yung physician po natin. Because the doctor, will give you, diba? And will order then, the drug of choice. So we have the pharma. Ano ba yung pharma natin? Ano ba yung drug of choice po natin dito, sir? Of course, walang ibang sagot. It's the amiodarone. The amiodarone. Are you aware that your amiodarone is a class 3 anti-arrhythmic drug which blocks the sodium channels, the potassium channels, and then we have the calcium channels. Now, pag sinabi naman din po nating amiodarone, guys, what's the dose here? This is with pulse kasi. So you give the half lang ng 300, which is 150 milligram. You flush it with 20 cc of plain NSS. Okay po. It should be given over 10 minutes. Huwag bilisan. Over 10 minutes lang po. Okay po. So ulitin ko. Sir, you need to seek physician consultation pag nag-VTAC with pulse. So tawagan si doc. Doc, we have a patient here, nag-VTAC si patient, doc, pero conscious naman. Okay, sige. Ayan, kamusta ang BP? The BP, doc, is stable naman po. Sige, kahit stable yan, bigyan pa rin natin ng amiodarone at 150 milligram over 10 minutes, and don't forget to flush it with 20 cc of plain NSS. Tulad ng adenosine kanina, i-flush mo din yan ng 20 cc of plain NSS. Just to make sure napapasok talaga yan sa systemic circulation. However, what if upon checking the patient's BP, and the VTAC here is less than 90/60, ang tawag natin doon, unstable VTAC. Guys, if unstable po ang VTAC ng client po natin, 2Ss na naman. For the first S, the same pa rin po, sedate. Ano yung ibibigay natin na drugs? Diazepam, midazolam, or pag wala pa rin, we have the propofol. And etomidate. Thank you so much, Doc. Next, we have letter S for the synchronized cardioversion po natin. As mentioned kanina, if we have a patient na suffering from ventricular tachycardia with an unstable BP, guys, kailangan pong mag-synchronized cardioversion at 100 joules po tayo. Okay? Pag SVT, sounds like 50. Pero pag VTAC na po, it should be at 100 joules po tayo. Okay? Now, we're done na sa ating pre-arrest setting. Let's have the arrest setting. I love discussing arrest setting. Why? Dito na kasi naglalabasan ang mga high quality chest compression. Defibrillate the patient and there should be no drugs na on the first scenario. Pag sa second scenario, combination na po nilang lahat. You need to perform high quality chest compression plus defibrillation plus giving off or administration of our drug of choices. Now, for the arrest setting, guys, we're going to perform the BLS survey. However kasi, the BLS survey here is hindi na po the same sa BLS na ginawa po natin outside the hospital. Baka yung iba kasi, no, yung mag-check pa ng ng environmental safety, checking for hazard. Just ko, wag na po. Nasa ER ka, 'di ba? Malamang safe talaga 'yan, na naalala ko lang talaga dati when I had my duty sa may Cotabato area. Tas biglang parang nagtakbuhan kami, guys. Kasi biglang may sumigaw na shotgun. So akala talaga namin may bit-bit talaga sila na shotgun. Yun pala, gunshot. Iba kasi ang shotgun sa gunshot, 'di ba? Gunshot wound. 'Di ba GSW? Diyos ko, no, pag narinig mo lang talaga ang shotgun, tapos sa may Cotabato area, grabe lang talaga. Parang Diyos ko, mas unang tumakbo yung mga yung mga spirito po namin. Pag gunshot wound, okay lang. Na parang okay pa siya. Pero pag shotgun na, ay iba na eh. Parang may bit-bit na, parang may gera na sa loob ng ER po namin. Okay, so we have the BLS survey. So again, do not say na the scene is safe, no BSI on. No, malamang nasa hospital ka, so malamang safe talaga yan. And if ever po na you need help, do not say help. Please activate the emergency response na parang tanga ka dun sa loob ng hospital. You can what? No, you can directly activate po the di ba, the code blue. Code blue to ER bed 1. Code blue to ER bed 1. And then malamang alam mo kasi ang pangalan ng pasyente. Do not say, hey, are you okay? Batawagin mo sa pangalan. Mrs. Fernandez, are you okay? Mrs. Fernandez, are you all right? Na, ayan, the patient, Mrs. Fernandez is unresponsive. Code blue to ER bed 1, please. Code blue to ER bed 1. Ayan, checking for pulse and breathing. 1,000, 2,000, 3,000, 4,000, 5,000. No pulse, no breathing. I'm going to start with my high quality chest compression. 1, 2, 3, 4, 5, 6. Ganun po. Ayan, bawal kang hey, are you okay? Dapat kilalanin mo, 'di ba, ang pangalan ng patient niyo po. Unlike sa BLS ng pre-hospital, syempre hindi talaga natin kilala ang patient natin. Pero na lang kung ex mo 'yan. 'Di ba? Tawagin mo sa pangalan, Junjun, are you okay? Or Marites, are you okay? Dapat ganon. Okay, let's have the arrest setting. With your arrest setting po, number 1, we have the VFib. And we have the VTAC, but this time, this will be a negative pulse or a pulseless, VTAC po natin. Guys, ano ba ang ginagawa natin? Number 1, this is on an arrest setting. So malamang wala talagang pulso dito. So we usually divide this one into class 1, class 2A, and then we have our class 2B. For the class 1, pagsisigaw po ang doctor po natin, class 1. Okay, let's perform high quality chest compression. Next, class 2A, let's defibrillate the patient now, charging to 200 joules. Next, sir, first pa kasing nakita si VFib-VTAC negative pulse, baka ma-okay po siya sa defibrillation, there should be no drugs muna. Ito yung protocol ha, based kay AHA. However, yung ibang hospital ay magbibigay na po sila agad-agad ng drugs. And I cannot blame you. Depende din talaga sa hospital protocol. But I'm just following the American Heart Association na protocol. Kaya daw walang drugs, baka kasi ma-okay siya sa defibrillation. Take note, your VFib, diba, sounds like defib, this is a shockable. VTAC no pulse is also a shockable. Baka ma-okay lang sila. No, at least hindi masyado tayo, diba, magko-cause ng let's say diba, magdagdag ng another burden kay client. At least na okay siya sa walang drug. However, 2 minutes up. Ayan, pag 2 minutes up na po, sasabihin ni team leader, let's SAS. Ay, gusto ko yan. Bakit SAS? Let's stop the compression, let's analyze the rhythm, and let's switch roles. Stop CPR. Analyze the rhythm or the ECG on screen, and then switch roles. Usually, ang nagsiswitch lang ng roles, kung sino yung nagdi-defib at kung sino lang yung nagko-compress. Ay, sila lang pala, sir, yes. Kasi, pag BLS talaga yan, si Airway at saka si compressor, sila lang talaga ang nagsiswitch. However, pag nasa code blue team ka na, standby lang yung Airway mo. Kasi usually ang Airway po are doctors and ready for intubation. Para pag sinabi ni doctor, okay, doc, let's say Doc Manuales, no? You can now intubate your patient kasi the patient's O2 sat na is less than 84%, and then may mga signs of, 'di ba, mga hypoxemia na si client, and then of course the GCS is less than 8. Now, so this is the best time for us na to intubate the patient. Lalo na pag nag-anticipate na po. May mga doctors nagpapa-intubate ng less than 90. Pero if we're going to follow American Heart, pag less than 84% po no ang kanyang O2 sat, and then no less than GCS na po of 8 no ang kanyang score, that's the time na magpapa-intubate na si doc. So depende pa rin kay doc kung gaano siya na alam mo yung nag-anticipate na baka papangit talaga ang situation ng patient na to, ang status ng patient na to. Now, stop, analyze, and switch roles. Okay, now, sir, still, VFib on screen. And VTAC ulit. VFib, VTAC pa rin, negative pulse. Guys, pag sisigaw ako, kunwari ako ang doktor mo, kunwari lang ha, ayan, class 1. Class 1, what's your answer? It should be high quality CPR or high quality chest compression. Class 2A and then class 2B. Yes, we need to defibrillate the patient at 200 joules. Next, sir, hindi rin kasi nag-effect po ang defibrillation natin kanina. So meaning to say, magbibigay tayo ng drug of choice. Now, listen carefully kasi this is based on American Heart. Ang sabi kasi, now you can give your epinephrine, okay, first dose. Now, first dose of epinephrine, 1 milligram. 1 is to 10,000 dilution. You flush it with 20 cc of plain NSS. Plain NSS and arms elevated. Arms elevated for about 10 to 20 seconds po. Ulitin ko ha. Epinephrine, first dose, 1 milligram. 1 is to 10,000 dilution. That 10,000 dilution kasi, I am referring to 1 ml of your epinephrine plus 9 ml of your plain NSS, making it 10 ml. Tapos, ipa-flush pa natin yan ng 20 cc. After administering that, 1 is to 10,000. Then, you're going to elevate the patient's, arms for about 10 to 20 seconds, no, just to make sure and by flow of gravity po, papasok talaga siya sa systemic circulation. And that's the first drug po natin. However, sir, ayan, what if lang ha, what if, na, ayan, what if wala pong epinephrine, na, ayan, mamaya, na may ibibigay po tayo mamaya, na, and sige po, so we have your, ayan, class 1. Next, what if 2 minutes, na, 2 minutes is up na po. And 2 minutes is up na. Ayan, ano kayang ibibigay? Ano kayang gagawin po natin? SAS ulit. Let's stop the compression. Let's analyze the rhythm and let's switch roles. Ayan, doc. The same pa rin po, doc. Ventricular fibrillation on screen or VTAC with negative pulse on screen pa rin. Now, tandaan po natin, epinephrine is given every 3 to 5 minutes. Ang sabi ko, 2 minutes is up. Meaning, meron pa tayong 3 minutes na gumagana ang epinephrine po natin. So, malamang hindi muna ako magbibigay ng epinephrine. Okay po. However, sa mga hospitals po, well, I cannot blame them. That's their protocol. Epi. 3 doses of epi, declare agad the time of death. Kawawa naman si patient. No? 75 pesos lang pala guys na ang amount ng isang buhay ng isang tao. 75 times 3. Kasi nakabili ako ng epinephrine last time nasa mga 75 ata or 70. Parang 75. Ewan ko ngayon kung baka nagmahal na siguro. Basta the last time na bumili ako nun was 75. And ayoko munang bumili noon. No? Siyempre, pag bibili ka nun, may nag-arrest, di ba? So ayun, we have here the VFib and then we have here the VTAC. Now, ganito. Pag sinabi kong class 1, ayan, class 1. Next, we have class 2A and then we have the class 2B. Pag class 1 po natin, ayan, we have the high quality chest compression. Next, pag class 2A, defibrillate the patient. Pwedeng 150, pwedeng 200. Pero since we started at 200, so malamang 200 din dapat. na wag ka nang wag nang mag-escalate po. Pag 150, 150 na, 200, 200 na talaga. Wag ka ding bumaba na from 200, bigla kang bumaba na 150. No. You started at 200, you're gonna end it at 200. Aside from defibrillating the client po, this is the time na we need to give another drug of choice. Dalawa po ang drug of choice natin dito. Number 1, we have amiodarone. In the absence of amiodarone, you can give your lidocaine. Now, the drug of choice will be amiodarone. Kaso, meron kasi tayong first dose. Meron din tayong second dose. Anong ibibigay mo dito? First dose or second dose? Edi first dose muna. No, ganito kasi yan. No drugs and then epi. Na tapos, ayan, next po will be amiodarone first dose. And then epi second dose. And then amiodarone second dose. Okay po? Wala na silang third dose, guys. Ha? Kasi if ever kung magta-third dose ka, kung ano yung second dose mo, yun din yung third dose mo. For the lidocaine naman, pag nasa States ka, they call that one as lidocaine. We have the first dose and then we have the second dose. First dose for the amiodarone po will be 300 milligrams. Ayan, you flush it with 20 cc of plain NSS and arms elevated for about 10 to 20 seconds. How about for their second dose? Their second dose will be half of 300 milligrams, which is 150 milligram. You flush it with 20 cc of plain NSS and arms elevated for about 10 to 20 seconds. Ayan. Can I see a thumbs up sign po sa ating monitor? Para at least na malaman ko na okay pa tayo. Thank you so much. Thank you so much. Thank you. Maraming salamat po. Medyo mas dumami po tayo, no? Naging 28 po tayo. Yan, nakaka-happy, nakaka-happy. Ayan, we have lidocaine. Guys, for the lidocaine naman po, dati kasi tinanggal nilang lidocaine. Bigla nilang binalik po. No? 2020 guidelines ng AHA, bigla nilang binalik. So, ayan, the first dose will be 1 to 1.5 milligram per kilogram. And then, if you're going to ask me what's the second dose, sir, of course, that's the 0.5 to 0.75 milligram per kilogram. Do I need to flush it pa rin, sir? Yes, with 20 cc of plain NSS pa rin. This is the updated version po ha. Kaya lahat ng mga emergency drugs ngayon, ang mga protocols talaga, if ever kung ipa-follow nyo, you can flush it with 20 cc of plain NSS just to make sure na papasok sa systemic circulation. So ulitin ko, paano magbigay ng drugs? No drugs first. And then, the first dose of epinephrine. Next, first dose of amiodarone. Next, second dose of epinephrine na the same pa rin. However, pag magsi-second dose ka na ng amiodarone mo, will be half na lang po ng first dose po natin. Kung amiodarone. Pero what if lidocaine ang gagamitin ko? Walang problema. No drugs. And then next will be the first dose of epinephrine. Next, the first dose of lidocaine. Next, the second dose of epinephrine, and then the second dose of amiodarone po. E di magla-lidocaine po tayo. Or the lidocaine. Kasi your lidocaine kasi, na yung mga procainamide po natin, they are antidysrhythmics din po. Okay? Ayan, sige. Next po will be the asystole. Akala ko lumindol. Puan ko lang pala. Ayan, we have the asystole and we have the PA. Guys, ayan, these are, of course, no, mga arrest pa rin na setting to. Are they shockable or non-shockable? Sige, anyone from the group?
Non-shockable.
Are they shockable or non-shockable? They are non-shockable. Great po. Thank you. Ayan, if they are non-shockable in nature, we don't need defibrillation here, but we need a, diba? And high quality, diba? Check for pulse, check for Ecg leads, and then you maximize 5 to 10 times asystole confirmed. Now, for the PA naman, na-discuss ko na kanina ang H's and T's po natin. Kasi pag na-identify po natin na H's and T's, okay, sige, na. Ayan. So, need to mga ventricular problems po. So we have a heart rate of 154. The rhythm is regular. Kahit wala P-wave yan, same po ang distance ng, ayan, R is to, all I can see are what? Now, widened QRS, this is your monomorphic ventricular tachycardia. This is monomorphic. However, ayan, what if ganito ipakita? The heart rate is 0. However, the rhythm is chaotic. Now, there's no P wave. It's QRS and it's widened. However, kasi, ang pagka-widen niya po ay magulo. No? It's in multi-form. So, this is an example. An example of ang kanyang magnesium. Okay, the patient's heart rate is 0. The rhythm is chaotic. There's no P wave, there's no QRS. Ang tawag natin dito, this is your what? Ventricular Fibrillation or the VFib. So guys, no, dapat isa puso, isa isip na po na ganito ang itsura ng VFib. Ayan, wag niyong kalimutan. Kalimutan niyo na lahat, wag lang si VFib kasi this is a sign, no, na ang patient po natin is suffering from a sudden cardiac death experience. Ayan, 'di ba? Time is gold here. Na the moment na na-identify po natin na okay, this is VFib, then 'di ba, with proper management po, then maganda po ang prognosis ng patient po natin. Okay? Now, aside from your ayan, the VFib, what if ganito ang nangyari? Upon arriving daw sa ER, nag-Sinus Bradycardia ang client. From Sinus Bradycardia, nag-VTAC. From VTAC, nag-VFib. And from VFib, biglang gumanito. Diba magulat ka from series of arrest? Ay, ba't ang bilis? Ba't parang may return of spontaneous circulation na agad? Tapos si doktor, sasabihin niya, okay, Mr. Adlawan, pa-check nga ng pulse ng patient natin. 1,000 to 1,003, 1,000 for 1,000, 5,000, doc. But parang walang pulso ang client. Yes, this is an example of a pulseless electrical activity. From series of arrest, akala mo may PQRST na, pero pag check mo ng pulso, wala pa rin palang pulso, then that's your pulseless electrical activity. Okay po ba? Next. Ayan. Let's have, okay, the discussion of your asystole and PA when it comes to their algorithm or protocol. So we have class 1. Now, for class 1, we have class 2, and then we have the class 2A and class 2B. For class 1 po, ayan, we're going to, perform high quality chest compression. Next, class 2A po natin, there should be no defibrillation. Kasi these are non-shockable rhythm po natin. Next, for the drug of choices po natin dito, or drug of choice, we have the epinephrine, 1 milligram, 1:10,000 dilution. You flush it with 20 cc of plain NSS and arms elevated, okay, for about 10 to 20 seconds. Arms elevated for about 10 to 20 seconds po natin. Okay po? So again, ang epinephrine po natin should be given every 3 to 5 minutes. Meaning to say, if ever guys, pag nag-reoccur ulit ang asystole po natin, what's our next drug? Hindi kasi pwede na epinephrine ulit eh. Hindi kung ano yung mga binibigay po natin pag arrest. So epi, amio, or epilydo. Again, this is just based on AHA. Pag sa hospital nyo pa rin is epi, then I cannot change that. Na? Pero kung depende kung mag-change kayo like epiamiodarone, then pwedeng ma-prolong talaga ang life ng client. Kasi as emphasized by American Heart Association, 3 consecutives po na na pagbigay ng epinephrine has no advantage na sa client. Kasi like wala daw siyang advantage. Mas maganda pa daw pag epiamiodarone, and epiamiodarone kesa sa continuous po ang epi. Tas declare patay si client. So mas okay daw ang prognosis pag epiamio or epilydo, epiamio or lido. Okay po? Now, let's try to emphasize na po the differences between epinephrine and your amiodarone po natin.
Is it So just to break down a couple of these interventions a little bit more, epinephrine is a vasoconstrictor. That's why we use it in cardiac arrest. As you probably remember from pharmacology, it's a non-selective adrenergic drug, meaning it acts on the alpha and beta adrenergic receptors all equally. The great thing about epinephrine is it increases systemic vascular resistance. So it clamps down all the blood vessels below the diaphragm, and it cuts off blood flow to organs we don't care about in cardiac arrest, like the liver and the kidney. What we care about in cardiac arrest is the heart itself and the brain, because those are the 2 organs that are going to determine our ultimate outcome in the setting of arrest. Unfortunately, even though it makes a lot of sense to give a medication that would optimize cardiac and cerebral blood flow, there's not really great scientific evidence supporting the use of epinephrine, and we'll talk a little bit more about what there is. So there's only one randomized controlled trial on epinephrine that's ever been done in the history of medicine, and it was just done a year or 2 ago by a group down in Australia. And basically what they found is that when epinephrine was given in place of placebo, for patients with out-of-hospital cardiac arrest, these patients were much more likely to survive the resuscitation itself or to get a pulse back during the resuscitation. And they were much more likely to survive their hospital transport and actually get admitted to the hospital. So they would live through their ambulance ride, live through their time in the ED, and make it up into an ICU setting. Unfortunately, there is no evidence that the group that received epinephrine was more likely to survive to hospital discharge. So while their short-term outcomes were a lot better, their long-term outcomes were comparable. One of the reasons for this is that unfortunately, the sample size of the study ended up being smaller than the investigators intended, and they weren't able to demonstrate a less likely outcome like survival to hospital discharge because they just didn't have the sample size to do it. So the bottom line is we still don't really know if epinephrine changes long-term outcomes in cardiac arrest and if it makes you any more likely to survive to the end of your hospitalization or to survive with a neurologically good outcome. Now, epi's a bit of a double-edged sword. So on the pro side for epi, we know that it increases vascular tone, optimizes perfusion of the heart and the brain, and it improves short-term survival, which clearly is an absolute prerequisite for long-term survival. So it seems like it would be a pretty good idea. However, remember what I told you causes cardiac arrest? It's mostly myocardial infarctions and other forms of ischemic coronary disease. So when you give epi, what does it do to the heart? It increases rate, it increases contractility, and ultimately it increases myocardial oxygen demand, which can worsen ischemia. Epi also does reduce perfusion to other organs, which is problematic, and we don't know what effect, if any, it has on long-term survival. It might do no good. It might even be harmful in the long run. We truly don't know. So hopefully we'll get more scientific evidence regarding epinephrine as time goes on. But for right now, experts in the field believe that the pros outweigh the cons, and generally it's considered the standard of care in cardiac arrest. So according to current protocols, epi is a mandatory intervention. You give 1 milligram of it in 1 to 10,000 dilution every 3 to 5 minutes throughout the cardiac arrest. Now, there aren't many drug doses you need to know cold, but this is one that you really should know both for your exams and for your life. 1 milligram of epi, 1 to 10,000 formulation, repeated every 3 to 5 minutes throughout the cardiac arrest. The other drug that was mentioned in our arrest algorithm is amiodarone. Amio, as you may know, is a class 3 antiarrhythmic drug, and it is indicated for all cases of shock refractory VFib and VTach. But the current Heart Association guidelines don't say you definitely should give this drug because it's awesome and saves lives. They say, meh, you can think about it. So it's not actually a mandatory intervention, and that's because there are 2 large-scale studies of amiodarone that have shown evidence of short-term survival compared to placebo. However, there's no evidence that amiodarone is superior to other antiarrhythmics, such as lidocaine, which was traditionally used in cardiac arrest, and there's no evidence that it offers any benefit whatsoever for long-term survival outcomes. That means that your patients will have had their cardiac arrest detected quickly. They will have received rapid CPR that's high in quality. They will have had their rhythm detected quickly and had a shock administered. So they've got a pretty good chance of intact survival if we can just get their heart restarted. Contrasted to patients we see in the ED who arrest at home or out in public places, who may or may not have a witnessed arrest, who may or may not receive rapid CPR and rapid defibrillation. These patients often have a much higher degree of cerebral injury, a much higher degree of cardiac injury from their cardiac arrest event, and they're less likely to benefit from amiodarone. So we have to be a little bit circumspect in whether or not we're going to use it in this population of patients. So the bottom line with amiodarone is it's used very commonly for refractory VFib and VTach that's not responsive to epinephrine and electricity. The dose is 300 milligrams, which is double the normal loading dose you would use for other indications. And you really should think about it in cases where you suspect that the patient might have a positive outcome if you can reorganize their cardiac rhythm, but maybe not useful to give it in patients who are likely to have severe cerebral anoxia and go on to have a bad outcome no matter what you do. So let's review the algorithm one more time. We're going to call for help, and we're going to start CPR as quickly as we can. We're going to go ahead and perform defibrillation, and fortunately for us, we're very likely to be able to get our hands on a defibrillator out in public because they've become so readily available in public settings. If the patient's in VFib or VTach, we're going to shock them. After the first shock, we're going to perform 5 cycles of CPR or 2 minutes by the clock, at which point we're going to give 1 milligram of epinephrine. After giving epinephrine, we're going to again resume CPR for 5 cycles or 2 full minutes, at which point, once again, we'll recheck the rhythm. If it's still shockable, we'll perform another defibrillation, and then we will consider the use of amiodarone, because at this point, we would consider the patient to be in shock refractory VFib or VTach.
This will be my last topic, known as the algorithm na po for the mega code. Kasi we will be dividing na, let's say we have the pre-arrest, and then we have the arrest, and then we have the post-arrest setting po. So just in time lang, before 12 o'clock, tapos na po tayo. Let's focus more of the pre-arrest setting. Kunwari nasa ER po tayo, ang setup po natin. Now with the pre-arrest setting kasi, my mnemonic will be the mnemonic vomit. Ayan. So here's the setup po nasa ACLS po natin. So we have the mnemonic vomit. Na pag sinabi po nating pre-arrest guys, letter V, you visualize the client. So there will be the verbalization. And then there should be the checking of vital signs such as the heart rate, the BP, the RR, no? And then we have here the O2 saturation of the patient. Ayan, isama na po natin si temperature din po natin. Kasi baka, di ba, what if may mga wait lang, but parang may hyperthermia ang patient po natin? Bakit may fever? So at least na maano din natin, makater din natin, baka possible na COVID client to. So ayun po, you visualize the client. Upon visualizing po, the client appears to be cold, clammy, diaphoretic patient. Verbalizing. Now, you approach your patient, you introduce yourself. Kunwari, pag doktor ka, no? Pag doktor ka, you introduce yourself. I am doctor. Ayan, how are you feeling today? If you're a nurse, good morning, Mrs. Fernandez. I am Mark Adlawan, your most responsible nurse. How are you feeling today? Okay. Sabi ni patient, I feel like I'm dying, Mr. Adlawan. Okay, Mrs. Fernandez, you seem upset. But before that, let me check your vital signs first. So the heart rate, the BP, the RR, the O2 sat, now we have the temperature. Now, for the O2 sat kasi, if the O2 sat drops to less than 94%, then that is not normal. Kasi the normal O2 sat should be 95 to 100%. Pag less than 94 na po yan, guys, you need to give O2 therapy na po tayo. So we have O2 therapy. So we have nasal cannula, we have the simple face mask, and then we have the non-rebreather mask. Simple face mask, and then we have the non-rebreather mask. With nasal cannula po, na regulated at 2 to 4 liters per minute po dapat yan. And then for the simple face mask, ayan, it should be at 6 to 10 liters per minute. And then pag non-rebreather mask at 11 to 15 liters per minute po. Careful lang po tayo ha. Baka kasi may COPD ang client, bawal po na mataas ang kanilang oxygen kasi hindi na po sila hihinga. So if you have a patient who's having a COPD, malamang Venturi mask dapat at 1 to 2 liters per minute dapat mo. Next, we have letter M for monitor. Ilagay po natin si patient sa 12-lead ECG. I-attach po natin ang 12-lead ECG sa kanya. Next, letter I. So we have the IV insertion and then we have the IO insertion. Question. Pag mag-IV po tayo guys, you go always sa left brachial vein ha. Left brachial vein po always yan. Dati kasi whether left or right. Ngayon dapat left brachial vein kasi mas malapit po yan sa puso na mas madali po siya i-pump going to the systemic circulation. So it should gonna be the left brachial vein. Na ngayon, dati kasi left or right. Pero ngayon mas ina-emphasize po ng AHA, American Heart Association, na dapat sa left side na po. Kasi andyan kasi located na it's proximal po sa ating heart. Next, letter T for treatment. No? So, depende na sa treatment natin, whether if it's Sinus Bradycardia, if it's SVT, no? Or if it's your what, no? Pulseless, let's say VTAC with pulse rather, VTAC with pulse. Kasi pre-arrest pa kasi tayo eh. Pero pag nag-arrest ka na po, ito na yon. Pag-arrest na kasi usually BLS na to eh. The BLS survey. But the BLS po na survey natin dito is based on the hospital, okay, intra-hospital setting, not the pre-hospital. So paano ba mag-intra-hospital? Tawagin mo lang sa pangalan. Mrs. Fernandez, are you okay? Mrs. Fernandez, are you all right? Mrs. Fernandez, unresponsive, code blue to ER bed 1, please. Code blue to ER bed 1. Checking for pulse and breathing. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. No pulse, no breathing. Let's start high quality chest compression po. Okay. Now, aside from the arrest setting, we have the post-arrest. Ayan, setting po natin. With the post-arrest setting po, you need to determine for the return. ROSC, guys, is the return of spontaneous circulation. Such as, number 1, if present na po ang pulse rate, if present na ang BP, and the PET CO2, the normal kasi is 35 to 45 dapat for the PET CO2 po natin, or the partial and tidal CO2. Now, question sir, ano ba ang ginagawa natin dito? Guys, yes, kung may pulse rate na, may return of spontaneous circulation. However kasi, meron kasing with pulse rate, tapos wala palang RR, so may gagawin tayo. And then pwede rin kasi na may BP si client, pero masyadong baba ang BP ng client. Don't worry. Patataasin po natin later ang BP ng patient by giving yung mga vasopressors po natin or fluid resuscitation pwede din. Pero depende sa case ng patient natin. Now, with, post po. So we have airway, breathing. Ayan. Next, we have circulation. And then we have disability or letter D. And then meron din po tayo ditong sign of the cross. Bakit kaya may sign of the cross? Patay ba ang patient? Malamang buhay. Ba't pa tayo nag-discuss ng ACLS kung mamamatay lang pala ang patient? Diba? Ayan, with airway, breathing, circulation, depende sa case ni patient. Yes, the patient has pulse rate, but the patient has no RR. Ang gagawin niyo po, rescue breaths. Yung na-discuss natin kahapon, guys, 'di ba? Pag adult, 1 rescue breath every 5 to 6. Pero pag may advanced airway, 1 rescue breath every 6 to 8. If ever naman less than 84% ang kanyang O2 sat, tapos less than 8 ang kanyang GCS, this is the time na kailangan i-intubate ang client. So there should be intubation by our lovely doctors, our competent doctors po. Next, letter C stands for circulation. Guys, ang ano kasi natin, ang problema talaga natin, no, usually after an arrest setting, hypotensive ang patient. Now, if hypotensive ang patient, we auscultate and we determine for crackles. We usually check for crackles. Why? If present po ang crackles or rals, meaning may fluid-filled lung ka, yet hypotensive si client, bawal kang mag-fluid resuscitation. But rather, kung may crackles, may rals, ayan, no, you need to give yung mga drugs natin such as D, letter E, and letter N. The dopamine, ayan, pag wala si dopamine, epi, pag wala si epi, norepinephrine. Now, for the dopamine po at 10 micrograms per kilogram per minute yan. Pag epinephrine naman po, we have it at 2 to 10 microgram per minute. And then, we have 2 to 10 microgram per minute naman po. Okay po? So, again, ulitin ko. Sa circulation natin, normally talaga hypotensive si client. So the quest here or the challenge here is that, ayan, ang lungs niya ba ay clear? Baka kasi, na yes, hypotensive si client, pero nung pag-check mo ng kanyang lungs niya, ba't parang may fluid-filled lung? Tapos mag-fluid resuscitation ka, mas lalo pong magkakaroon ng pulmonary edema. 'Di ba? And so mas lalo magkakaroon ng ng pulmonary congestion, not edema but rather congestion. Congestion kasi yung pinakalaban talaga natin eh. So eto na. What if naman negative crackles naman, sir? No crackles, no rals si patient. Do you think safe bang magbigay ng fluid resuscitation? Yes. So you can administer 1 to 2 liters of IV bolus of plain NSS. Meaning it's a fast drip po natin yan. Don't worry kasi wala naman po tayong fluid-filled lung eh. So kung may fluid-filled lung po tayo, kung gusto mong patasin talaga ang BP ng client, then you can give dopamine or epi or norepi. Mamili ka lang ha. Huwag mong ibigay lahat. Pakasabog din yung heart ng client mo sa sobrang bilis. Next, we have your crackles. Pag negative crackles naman or walang rals, yes, you can have your fluid resuscitation. Ang tawag kasi dito, fluid resuscitation or magpa-fast trip lang po tayo ng 1 to 2 liters of IV bolus of your plain NSS. And then lastly, we're going to have the sign of the cross. Paano ba mag-sign of the cross? Ayan, we have NGT. Next, we have Foley cath. We have 12 lead, ECG. And then we have the portable X-ray. And then we have the central line axis or the CLA. This is the central line axis po. Ulitin ko lang ha. Bakit kailangan may NGT? Kasi before mo sila, i-refer po sa ICU. 'Di ba? To continue kasi, yun kasi yung goal natin eh. Kaya tayo may mga post-cardiac arrest, the PCAC or the post-cardiac arrest care para hindi po magulay ang patient natin. So to have ma-maintain po yung nutrition, administration of medication, gavage, lavage. Diba gavage is give for nourishment yan. Lavage naman, lavas na for irrigation naman siya. And then we have the administration of medications po natin. Next, for the Foley cath, we're going to monitor po sa urine output ng client because a good urine output must have, diba, malamang maganda din ang kanyang cardiac output. For the 12-lead ECG naman po, na to capture, diba, the complete picture on what's happening sa heart po natin. Kaya dapat may 12 ECG before i-transfer sa ICU. And then we have the portable X-ray. Guys, question, bakit kailangan may X-ray? Number one, kanina pa kasi tayo nagko-compress. And then this is the time to rule out ng pneumothorax. Yun talaga yung goal natin. Kaya pala absent ang breath sounds ni patient kasi may tension pneumothorax na ang client po natin. And then next, we have the central line axis. Ayan, to know whether kung may hypervolemia or hypovolemia po. Okay? Ayan, sige. So, ayun. And then after our sign of the cross, this is the time na we need to refer our patient to the what we call as the intensivist ang tawag doon. Sige nga, everybody say intensivist.
Intensivist.
Ito po yung mga tao na nasa ICU. Maraming salamat po, doctors, nurses, midwives, and medtechs all over Philippines. Thank you for listening. Now, that's the end of our BLS-ACLS na training seminar po. Ayan, question. Let's have our question and answer portion. Question and answer portion na po tayo, guys. Sa lahat ng 27 po na nakikinig, for sure may mga katanungan po iyan. Pero kung wala din problema sa akin. Ba't ko naman pipilitin, di ba, na magtanong kayo? Ayan. May mga katanungan po ba? Ma'am Joy? WePump admin? Ready na po ba yung exam nila?
Yes, madam. Ipasend ko po.
Sige, ma'am. Thank you, ma'am. Ma'am, dalawa lang po daw sila, ma'am, na magfe-phlebotomy. So far, Doc, basta si dosage naman, wala namang titrate rather sa lidocaine. Basta i-follow lang po natin yung dose niya na sa first dose is 1 to 1.5 milligram per kilogram, tapos sa second dose it's the 0.5 to 7 to 0.75, tapos mag-flush lang po tayo ng plain NSS. So far yun lang naman yung based sa manual ng American Heart at sa sa mga conferences po namin.
Tatlo sila, madam.
Ma'am Joy?
Ano po silang mag-phlebotomy dapat?
Tatlo? Pero if ever kung i-reschedule natin sila, ma'am, okay lang sa kanila, ma'am.
Kung okay sa kanila, madam, wala naman sa akin problema.
Yes, ma'am. Para at least dapat madami-dami sila. Ay, wait lang. Sino po yung kahit pahabol na yung natin for the phlebo natin? Okay lang ba sa inyo, Mr. Prades?
Si Mr. Chavez, Mr. Prades, and Miss Darilay ang mag-phlebotomy.
Miss Darilay, i-reschedule po natin yung yung phlebo. Okay lang po ba, Miss Darilay? Wala ata si Miss Darilay. Ayun. Miss Darilay. Okay lang ba? I-reschedule natin kasi tatlo lang tayo eh. Pero ang importante na push po natin si BLS at si ACLS. Tsaka sino pa yan, ma'am? Okay na daw, ma'am, kay Miss Darilay. Okay, Mr. Chavez. Hello, Mr. Chavez. Saan ba si Mr. Chavez? Sir Chavez? Ay, Miss Chavez, sorry. Miss Chavez, Alonica. Ma'am? Okay lang ba sa'yo, ma'am? Kasi tatlo lang po for phlebo later. Para mas maganda kasi mas madami kayo. Pero, di ba, Ma'am Joy, tama ba ako? They will be receiving the certificates na ng phlebo. Tapos pahabol na yung nila.
Pwede naman po.
Okay. Sige. Mag-chat na lang po ng mga concerns po natin. I-chat na lang po si Ma'am Joy. May mga katanungan po ba before po tayo mag-proceed na sa ating post-test? Sige nga, pa-on nga po ng mga videos nila. Pa-on ng mga